Hello. Good morning, all of you. I am Dr. Manish, organizing secretary of this CME and workshop. It's a two-day event. One day CME on chronic pain lectures, and second day will be the cadaveric workshop on various modalities and various areas to touch in the chronic pain which are non-cancerous. So we have CME. In the CME we have 9 lectures and we have 7 interventions for cadavers. At 11 o'clock we will have our inauguration, and at 1 p.m. we have our lunch. So those who are fasting today have additional lunch over there for fasters. And after the completion of all the lectures today, there will be a quiz. And quiz will be accompanied by the prizes for first, second and third. So now I am starting our first lecture, which will be delivered by Professor Naveen Malhotra, and now Shashank will take over.
Good morning, everyone. Chronic pain is a burden that has substantial clinical, social, and economic impact. It is the aim of all pain physicians to identify and treat pain with full conviction. This CME will open your mind and broaden your outlook towards chronic pain and its management. So stay adhered to your seats and take full advantage of this academic feast. To begin with the first session on approach to a case of low backache, we have with us Dr. Naveen Malhotra sir, Secretary ISA National. Due to some unforeseen circumstances, sir would not be able to attend the CME personally, but he has sent a recorded video for us. Sir is a designated professor of anesthesiology and in charge of pain management center in PGIMS Rohtak, Haryana. He has the qualification of MD, DNB, FIPM, FIC and FIAPM. He is honorary secretary ISA National. His area of interest is chronic pain management. He has been awarded with ISA Bhopal Award for Academic Excellence in the year 2015, KPR Young Anesthesiologist National Award in 2009. He has over 197 publications to his name and presentation more than 405. His original works are submentotracheal and retromolar intubation. Let's begin with the video.
Good morning, all. Thank you, team KGMU Lucknow, for inviting me to deliver a talk on how to approach a patient with back pain. I would have loved to be there physically at Lucknow, and I had a very warm invitation from Dr. Sarita Singh, Dr. Manish, and I also acknowledge the presence of Dr. Pankaj Surange, Dr. Anil Agarwalser, and very dear Dr. Anurag. I'll definitely like to join you in near future. Back pain is a very, very common clinical condition which we daily see in our pain clinics, left and right. I bring with myself greetings from my institute, Postgraduate Institute of Medical Sciences, Rohtak, Haryana, and this is our OPD complex, and this is our pain management center, the Dard Nivaran Kendra, which I am heading right now. And I'm happy to share that it is a very busy pain management center with OPD like any other orthopedics, gynae, or medicine or surgery OPD, and lots of interventions done in the pain clinic and also on the dedicated pain OT days. And these are the pictures of pain OT in our clinic, the 6-bedded recovery room, and a good holding area for patients. I can say you that last 2 decades have seen an explosive growth in the scientific study of pain and anesthesiologists taking up pain medicine as an exclusive career and becoming the pain physician. We can build an exclusive career in pain medicine as an anesthesiologist because we are well versed with the art and science of treating pain, and our role as pain physician is a natural extension of our professional work. And most importantly, we are not behind the scene, we are directly interacting with the patients continuously over weeks and months. So those of you who are going to take pain medicine as a career, don't worry if you're not where you want to be yet, because great things take time. I'll start with a live scenario in pain clinic. I've divided my talk into 2 parts. One is a live scenario in pain clinic and then some theoretical aspects. A patient comes to you in pain clinic, you're sitting there. I can tell you in our own experience that every alternate patient complains of low back pain, pain in the lumbar region, and some have lumbar corset already in situ. When they come to us, the live scenario is, they say, Doctor Sahab, कमर में दर्द है, जकड़न है, उठा नहीं जाता, चला नहीं जाता, जब लेट के बैठ के उठता हूँ तो बहुत दर्द होती है, चलने से दर्द बढ़ जाती है, ज़्यादा देर खड़े नहीं हो पाते हैं, बैठने लेटने से आराम पड़ता है. Some people say that डॉक्टर साहब पेन टांगों में भी जाती है, ऐसा लगता है जैसे सुइयाँ चुभ रही हों, कीड़ियाँ चल रही हैं, झंझनाहट हो रही हैं. Leading questions which we ask are, पाँव में कोई सुनपन भारीपन तो नहीं है, पंजा उठा के दिखाओ, ग्रेट टो की मूवमेंट करके दिखाओ, और कोई आपको लैट्रिन बाथरूम की दिक्कत तो नहीं है, पेशाब उतर रहा है ढंग से, लैट्रिन बीच में तो नहीं निकल रही. So with this we focus on any sensory or motor deficit and bowel and bladder involvement. Then definitely ask more questions. दर्द कब से शुरू हुआ, कितना टाइम हो गया, क्या कर रहे थे जब आप दर्द शुरू हुआ. मेजॉरिटी ऑफ द पेशेंट से कि डॉक्टर साहब पूजा कर रहा था, उठा, दर्द हो गया, आगे झुक के काम कर रहा था, वजन उठा रहा था, एक्सीडेंट हो गया, गिर गया, एंड उसके बाद से दर्द शुरू हो गया. We should always ask about the work profile of the patient, because that will determine the interventions which you are going to plan or the treatment protocol you are going to decide. Suppose there is a patient who has got only few leaves, army personnel, patients who are working as in call centers, or IT personals who don't have that much leave. So there you have to go for aggressive treatment, early investigations, early interventions. 60-year-old female with back pain, with radicular component, डॉक्टर साहब मुझे सिर्फ चाय बनानी होती है, अपना पूजा पाठ करना होता है. There you can go slow also. So I'll tell you in beginning also, there is no tailor-made approach for a patient with low back pain. It has to be individualized, it has to be according to the patient. We have seen in our own Haryana profile or patients coming from northern India that majority of the patients are between 20 to 50 years of age group, and majority are females. Why females? Because females, they are working in fields, they are involved in household jobs which involve forward bending, weightlifting and other things, and they are more prone to low back pains. Always rule out the comorbid conditions, especially in older people who may have diabetes, who may be on anticoagulants, because that will affect your choice of interventions and timing of intervention also. Then definitely you do the examinations, you do certain tests which I shall be discussing, whether they are the Slr test or Faber's test or other provocative tests. And always you have to ensure, find out what are the dermatomes which are affected. If it is a radicular component of the pain, whether the pain is in L4, L5 or L5S1, unilateral or bilateral. The possible pain generators from where the back pain may come can be a disc, intervertebral disc, facet joint, muscle and ligaments, sacroiliac joint, coccyx, and so on and so forth. We'll come to them one by one. And then we go for investigations. Usually patients come to us with an X-ray in hand, and MRI is invariably done before interventions because we want to be very sure of the lesion from where it is coming, and also at the same time rule out caries spine, which is not uncommon in our part of country. And the treatment is divided into conservative, intervention and surgery. As I have told you, there is no tailor-made approach, but definitely intervention should not be delayed and they should be done. The indications for surgery are, pain is not an indication for surgery. The indication for surgery are if there is a foot drop, severe motor deficit, or bowel and bladder involvement. Then patient should be asked not to delay surgery. Otherwise, 95% of the patients are managed with either conservative or interventions. In our scenario, suppose we see 200 patients in a day, and suppose 120 patients are of back pain. Incidence of interventions is between 15 to 30%. So we can be as low as 15%, as low as 25%, and others can be managed with conservative treatment. So managing back pain depends upon thorough history and clinical examination. MRI proven to rule out caries spine, which is not uncommon, as I have said you, and initial line of treatment in majority of the patient is conservative with analgesics, neuromodulators, muscle relaxants, physiotherapy, precautions, and lifestyle adjustments. And I tell you that few drugs which are very, very commonly used for these patients are analgesics. If I told you that analgesics, you cannot give the commonest one which are used for analgesics are diclofenac, but not more than 2 weeks, tramadol paracetamol combination, or tramadol sustained release. Combined with muscle relaxants, you can combine with thiacolchicide, you can combine with chlorhexidine or tizanidine, and neuromodulators. Yes, if there is a regular component of pain or pain is long-standing and you see that there is a neuropathic component of pain, gabapentin, pregabalin are invariably combined, and we should be very thorough with their pharmacology of using these drugs. Our experience is in our profile patients usually do not tolerate more than you can say 600 to 900 milligrams of gabapentin. We typically start with 300 milligram HS dose, gradually increase it to 600, and very rarely some people require 450 milligram BD. And pregabalin, yes, definitely it is theoretically better drug than gabapentin. You have to just take care if the patients are not on diuretics because it causes fluid and water retention, and at times there is vertigo also. 75 milligram HS increase after 3 to 5 days by another 75 milligrams. Usually we patients tolerate in our setup by up to 225 milligrams of pregabalin. And definitely we'll ask them to do certain precautions. नीचे नहीं बैठना, आगे झुक के काम नहीं करना, और वजन नहीं उठाना. These 3 precautions, so we definitely tell them with patients with low back pain. Those with SI joint pain, definitely we tell them कि ज़्यादा देर बैठे नहीं रहना, ज़्यादा देर खड़े नहीं रहना, चौकड़ी उकड़ू आलती पालती मार के नहीं बैठना, सीढ़ी कम से कम चढ़नी है. Those with Oxycodonia, we definitely said please do not sit on hard surface, लोहे की कुर्सी, फर्श, प्लास्टिक, पत्थर, इनके ऊपर नहीं बैठना. And patients at times they think that if they sit on a patadi, a small chalky type, that is not sitting on the floor, but we have to tell them that the height should be as that of a stool or a chair. Before that, below that is something which is counted as squatting only or sitting on the floor only. Try to do the things while standing. Patients typically ask, डॉक्टर साहब झाड़ू मारना होता है, लंबा झाड़ू ले लो. डॉक्टर साहब पोछा मारना होता है, वाइपर से पोछा लगा लो. डॉक्टर साहब बर्तन धोने होते हैं, खड़े होकर सिंक में बर्तन धो लो. डॉक्टर साहब रोटी बनानी होती है, चूल्हा तो नीचे है, तो हमारे गांव के मरीजों ने चूल्हा फट्टे के ऊपर रख लो. So these are the practical things where you have to, patients teach you and you teach the patients. And definitely then you're combined with physiotherapies, ultrasonic massage, interference therapy. We personally don't go for tractions and no the Vana, Malvana, Rangadba, कोरिया का मशीन, रोलर थेरेपी. वी टिपिकली से आदमी मशीन को ठीक करता है, मशीन आदमी को ठीक नहीं करती. And as I was talking, nortriptyline is a very commonly combined drug in the doses of 10 to 25 milligrams, and it works excellently. And then we have to go for minimally invasive pain and spine interventions. They should not be delayed at all. And the commonest one are for the back pain, if it is disc is involved and there's a nerve root compression, the transforaminal nerve root blocks are the keystone of any interventional procedures. And the other ones are epidural injections caudal, interlaminar, parasagittal root. If pain is coming from facet joint, then you have to go for facet joint, either intraarticular injection or a diagnostic medial branch block followed by radiofrequency. SI joint injection, intraarticular injections do good. Ganglion impar block injections with local anesthetic and corticosteroids. Neurolytic if it is a malignant one, or radiofrequency ablation. Now, whether these MIPSs should be how image guided or not, nothing doing with anatomical landmark guided. It has been proven beyond doubt that if you do an ALG guided blocks, it is up to as high as 40 to 45%. Either you are at a wrong place, you are extradural or subperiosteal, and even in the hands of the experienced one. So we commonly used fluoroscope guided blocks because we are tuned to that. But yes, USG is also a modality, but the gold standard still remains for MIPSA is fluoroscope guided interventions. Majority of the procedures are done in prone positions, whether they are the epidural injections, transforaminal, SI joint, G impar, and some interlaminar approaches can be done in lateral or sitting position. Another question which patients ask you, Doctor, kitna injection lagenge? So you have to be very, very clear. What we say in our setup is कि 70% मरीजों को 2 इंजेक्शन लगते हैं, 10% मरीज को 1 लगता है और 20% मरीज को 3 लगते हैं. So you typically set the ball rolling and do not say that, and we typically say there is no magical one injection. You may improve with one, but we keep them mentally prepared for a second intervention after 4 to 6 weeks. Now that was about the clinical scenario when a patient comes to us in a pain clinic with a back pain. But coming to the other aspects, we know that IASP has refined the definition of pain in July 2020 as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage with 6 footnotes. You all have to go with that. And low back pain is a very important clinical, social, economic, public health problem affecting the population indiscriminately. And its physical burden is as high as CHF, COPD, or cancer. And it is the most common type of chronic pain which has been reported to have a lifetime prevalence of 54 to 80% and very common in 20 to 50 years age group. It can be acute if it is less than 4 weeks, subacute 4 to 12 weeks, chronic more than 12 weeks. And the majority of the low back pain stems, as I've told you, from falls, jerks, slipping, motor vehicle accidents, lifting heavy weights, incorrect postures, and age-related degenerative changes. Issues which can cause low back pain are the disc, the nerve root, dura, muscles, ligament, fascia, and facet joints. Pain from lumbar disc herniation can arise from nerve root compression or stimulation of nociceptors in the annulus or posterior longitudinal ligament. The various proposed mechanisms for radicular pain include chemical irritation and inflammation, intraneural edema, impaired microcirculation, partial axonal damage, neuroma formation, and focal demyelination. The patient usually has pain that may be central in the back, ऐसा बीच में कमर में दर्द है, usually in the lumbosacral region, and may refer down or radiate down to one or both lower limb. The symptoms clinically include muscle spasm or weakness, paresthesias, restriction of spinal movements, change in posture. एक limp आ जाता है और majority of the body weight is taken by the non-painful leg. Lurch is seen usually in the patients coming. They may have limp on walking, difficulty in getting up from sitting posture, and disturbed sleep. We have to go for certain test, and SLR test or the straight leg raise test, also called as Lessagas test, is very commonly done to determine whether a patient with low back pain has an underlying neural component due to herniated disc and mostly at a lumbar spine level. With the patient lying down on his back, the examiner lifts the patient's leg when the knee is straight. And if the patient experiences pain between 30 to 70 degrees, then the test is positive and herniated disc is likely to be the cause of pain. So with the SLR test, the meta-analysis have shown it to having sensitivity of 91%, specificity is 26%. And with cross straight leg raising, that means if the raising the opposite leg causes pain, the sensitivity is 29% and specificity is 88%. So at the same time, you have to also do the reflexes also, the quadriceps reflex and the tendocalcaneal reflexes, which may be diminished when there is a pressure on the corresponding nerve root. Coughing and sneezing usually provokes back and leg pain, and palpation over the lumbar spine provokes tenderness when the pressure is applied. Now this diagram is very, very important. You can have a printed this thing on your table also to know on the anterior and posterior aspect of the lower limb where the pain is coming, so that you can clinically know which dermatome is affected, whether it is S1, L5, L4, and this is a very, very useful diagram for the clinicians. So the overall diagnosis of low back pain depends upon patient symptoms and physical examination, neurological tests, as I have told you, and then we do go for X-ray and MRI. MRI is invariably done to know about the protrusion, extrusion, bulge, annular tears, degenerative changes, ligamentum filament hypertrophy, lumbar canal stenosis. All these are known on MRI. And we as a pain physicians should know about the interpretation of the investigations, whether they are the X-rays, where we can see that there is a disc space is narrowing and osteophytes are present, or whether it is an MRI T1 image or T2 image. In the T1 image, the tissues which are having fat, they are bright, the bone marrow, the spinal cord, subcutaneous fat, the epidural fat, and nucleus pulposum. CSF, which is watery, will not be appearing white, that will appear on T2 image. Those which have fat and water, like CSF, they will appear brighter on T2 image. So we should know interpretation of the MRI, T1 and T2, and that can help us about the patient with lumbar disc herniations, stenosis, and listhesis also. So these are the common scenarios which are there: herniation of the disc, stenosis, ligamentum flavor thickening, and listhesis. So there can be a bulging disc and ruptured disc or a herniated disc, and the fragment of disc material can then press the nerve roots. So MRI is a very, very useful tool, and I repeat, it also serves out to rule out caries spine, which is not uncommon. So as a pain clinician, we should be a good doctor, and good doctor should observe, record, tabulate, and communicate. We should use our five senses, maybe the sixth sense. Be transparent and informative to the patient. Be honest. Be confident of ourselves, but very caring at the same time. Competent in our knowledge, social and communication skills, and we should show respect to each and every individual patient and his or her symptoms. It has been rightly said that a good doctor treats the disease, but the great doctor treats the patient who has the disease. So we have to treat the patient as a whole, but not only the disc, right? We have to treat the patient as a whole, that he is able to carry out his activities of daily living in a pain-free manner, and his quality of life is improved. So it is a multimodal approach to the low back pain management, whether it is pharmacotherapy, whether it is psychological support, physiotherapy, MIPSIs, all have to combine together. And multidisciplinary, they all, as I've told you, focus on short-term analgesics, muscle relaxants, anti-inflammatory drugs, physical therapy, restriction of heavy activities, bed rest. Some patients who are on government job, they ask for rest, but we never usually give rest more than 1 week after the initial onset of symptoms, and 2 to 3 days after giving any intervention. But even if we do any MIPSIs, we typically say, जो काम कल कर रहे थे वो कल कर सकते हो, आज का दिन आपने एक्टिविटीज को रिस्ट्रिक्ट करके रखना है. So MIPSIs, consistent with the general trend of minimally invasive treatment approaches, the first intervention is epidural steroid injections, which are commonly used with increasing frequency because they are very less minimally invasive, safe, and cost-effective treatment. The epidural administered corticosteroids can be triamcinolone, dexamethasone, betamethasone, and they inhibit the synthesis of prostaglandins, have anti-inflammatory effects, and inhibit ectopic discharges from injured sensory nerves. Herein, I am not going into the controversy of particulate versus non-particulate steroids, but yes, definitely non-particulate steroids are better. The purpose of epidural steroid injection is to deliver medication close to the site of pathology, that is the effective nerve root, and the corticosteroid delivered into the epidural space attains higher local concentration over an inflamed nerve root and is more effective than a steroid that has been administered orally or intramuscularly. The various factors which affect the epidural corticosteroid injections are inadequate delivery of corticosteroid to the target site. We know that it has to go into the anterior epidural space, then only it will be effective. There may be inappropriate post-block activity, misinterpretation of pain generator, very, very common. Your diagnosis has to be bullseye based on history examination and investigations. And route of delivery into the medication into the epidural space, which is technically very important. The route of delivery, the routes can be transfemoral nerve root injections, most commonly done. The others can be caudal epidural injections, midline interlaminar epidural injections, or parasagittal interlaminar epidural injection. Transforaminal nerve root injection is very, very target specific, requires the smallest volume to reach the primary site of pathology, that is the anterolateral epidural space and the DRG. The injectate spreads peripherally around the nerve root and medially through the intervertebral foramen to the ventral epidural space, a site where the posterior annulus interface with the ventral aspect of nerve root and thecal sac. So they are very, very target specific, low dose is required, and you typically go at the site of pathology. They are done in prone position under fluoroscopic guidance, and you typically see a nerve root and it's an anterior spread. I know there is a workshop, so all these technical aspects, the approaches will be discussed during the workshop also. Caudal epidural, though it is a relatively easily achieved technique with minimal risk of inadvertent dural puncture, but it necessitates a substantial volume of fluid and thus the dilution of specific injectate or steroid. Even though we are doing it under guidance, but we have to rule out intravascular uptake. It is commonly useful for if there is a bilateral L5S1, L4, L5 involvement. So instead of giving 4 injections, you initially give an epidural injection through a caudal route, done in prone position, under fluoroscopic guidance, see a typical Christmas tree appearance as seen here, and ensure that the drug is reaching up to the affected level. It can be done under USG guidance also, and you can see the sacral cornu, the sacrococcygeal ligament, the sacral hiatus, and the sacrum. And you initially, this is the caudal epidural space, the needle goes in, and then you put a mosaic pattern and see the spread of the injectate. However, you can ensure that the needle is going into the epidural space, but whether it is reaching up to the affected site is not confirmed with the USG, or that fluoroscope is the gold standard. Interlaminar, with the interlaminar approach, the entry is more close to the site of pathology, facilitating the delivery of injectate to the target site, requiring lesser volume than the caudal route. Still, extradural placement cannot be ruled out in all patients, and there is inherent risk of dural puncture, though with inexperienced hand it is very, very less. And the preferential cranial flow of solution in the epidural space necessitates that the needle should be positioned a level below the site of suspected pathology. And that can be difficult at times if the suspected pathology is L5. So you cannot, it's difficult to place the needle below that. And it can be affected by presence of ligaments, scarring, which may prevent migration of posteriorly administered drug into the anterior epidural space. So this is the midline approach. It can be done, usually done in prone position under fluoroscopic guidance, but it can be done in lateral or sitting position also. And in the parasagittal approach, we use the most lateral aspect of the epidural space to administer the drug. And it has been suggested that with this approach, it is clinically more effective than midline, as greater anterior epidural spread of the drug is achieved. So you have to do it under fluoroscopic guidance and ensure that on fluoroscope you achieve the anterior epidural spread of the drug, which seems to be better than midline interlaminar. If patients come with post-back surgery syndrome already there, so we may have to go for adhesions. Rex catheter and PVC catheter are commonly used. We personally use PVC catheter with saline and hyaluronidase. And suppose the nerve root is entrapped here, and you can see that the drug is going here. So you have to do adhesionolysis and ensure that the drug migrates up. There are some procedural adverse effects of epidural injections, which can include infection, very, very uncommon nowadays, direct trauma, bleeding, hematomas, intravascular injection, very, very uncommon because you are knowing that there is no intravascular uptake of the drug, or you can reposition the drug, inadvertent dural puncture. All said and done, the incidence of side effects is very, very minimal if done under image guidance and with experience. Moving further from disc to the facet joint, it is another common cause of pain in patients, and its prevalence is 15 to 45%. and it increases with age, and which is as high as up to 90% in patients with 60 to 70 years of age. And facet joint arthritis is very, very common, especially at lower lumbar levels. Facet joints are also known as zygophysial joints. They are paired diarthroidal articulations between posterior elements of adjacent vertebra. They are formed by the articulation of inferior articulate process of one vertebra with the superior articular process of the adjacent vertebra. So the two articular process, they meet where the facet joints are formed. And they are innervated by the medial branches of the dorsal rami or the spinal nerves from L1 to L4 nerves. And each segmental medial branch of the dorsal ramus supplies at least two facet joints. For example, L4, L5 lumbar facet joint is innervated by the medial branches of the dorsal rami from L3 and L4. So it will receive from one at the same level and one above. The lumbar facet joints have been shown to be capable of being a source of pain in low back pain and referred pain in lower extremity. However, the discrete referral patterns from facet joints and the distribution of pain is overlapping from L1 to S1 level. So it is basically a clinical diagnosis. There is no discrete referral pattern which can be accompanied. You may have tenderness over one or more facet joints when you compress. Morning stiffness or pain worse in the morning is seen with facet joint arthropathy and typically improves with movement. The provocative tests are spinal extension, lateral rotation, or a combination of these activities. Apparently, facet joint pain is not being diagnosed accurately utilizing conventional clinical and radiological techniques. MRI may be normal at most of the times. So we may have to go for diagnostic blocks with local anesthetics. The reasoning is that if it is a pain is coming from facet joint, injection of local anesthetic will block the pain and the diagnosis will be confirmed. And subsequently, you can go for definitive procedure. Most commonly done is radiofrequency. So you can go for a facet joint intraarticular injection or a medial branch block diagnostic followed by radiofrequency ablation. So these are the blocks which will be shown in your workshops also. The intraarticular injection done under fluoroscopic guidance, and you see the spread of the drug into the joint. And you can go for a diagnostic medial branch block followed by radiofrequency ablation. It has to be done at multiple levels if required. Moving further down, the pain may come from sacroiliac joint leading to sacroiliac joint arthralgia. It is a large articular shaped diaphragmal synovial joint, and the anterior third of the interface between sacrum and ilium is a true synovial joint, and the rest of is comprised of ligamentous connections. Usually we go in the lower 1/3 approach posteriorly, and it is susceptible to arthritis, trauma, and degeneration, which can lead to pain and dysfunction. The pain may be felt in posterior superior iliac spine, buttocks, groin, thigh, gurotrochanter, or lower lumbar region. So usually it does not radiate below the knee joint. The provocative tests are the commonly used one are Faber's test, flexion, abduction, and external rotation, compression of the SI joints, and there are other tests also which help in aiding the diagnosis of pain coming from SI joints. Always get an MRI done. As I've told you, caries is not uncommon. Neoplastic infiltration can also be there. And conservative treatment is given as discussed with low back pain. And if pain is not improving, then you can go for SI joint injections under fluoroscopic guidance. As I've told you, seeing the complete spread of the dye all over the joint, usually we inject in the lower 1/3. It can be done under USG guidance also, where we can see the posterior superior iliac spine and the sacrum and put the needle. Just touching with SI joint, piriformis syndrome. Here the interventions are done 1 centimeter below and 1 centimeter lateral to the lower end of the SI joint, and see the drug spread below the piriformis muscle, where it can impinge on the sacral, into the sciatic nerves, and it is done under fluoroscopic guidance, and you can see the spread of these drugs with piriformis syndrome. Moving further, Oxycodonia. Oxycodonia is pain in the tailbone, which is commonly seen in patients who have a fall in washroom or stairs. 85 to 90% are managed conservatively. Initial treatment is analgesics, anti-inflammatory, chimeral 4, and hot fermentation, ring application. And if it is not subsiding, we go for ganglion impar block, either through the sacrococcygeal approach or through the intercoccygeal approach, done under fluoroscopic guidance. 23 gauge finer needle through the sacrococcygeal approach or the intercoccygeal approach. And you see reverse comma shaped appearance of the ganglia impar, and you put the drug. In patients who are non-malignant, we put 10 ml of solution of local anesthetic, 8 ml of 0.25% bupivacaine with 80 milligrams of corticosteroid, or those patients who are having malignancy, C. rectum and C. perineum, we go for neurolytic block with 6% phenol. And we commonly do radiofrequency ablation of G impar block also. Pain may come from myofascial pain syndromes, and trigger point injections usually do well. You do with a mixture of 0.5% bupivacaine with rinsed with local corticosteroid in fan-shaped manner. They are helpful at times. The other interventions involve nucleoplasty, spinal cord stimulator, DRG stimulator, endoscopic procedures like disectomies, foraminectomies, and vertebral augmentation in patients with compression fractures of spine. They will be covered in your workshop. So I conclude my talk with saying that the management of a patient with low back pain is just like breaking this matki of pain, which relies on a thorough foundation of history, examination, relevant investigations, and early interventions. Then only this matki of pain will be broken. This is the picture of Dahihandi festival of during Ganesh Chaturthi, and then only this matki of pain will be broken, and it is a holistic approach. I thank my team, which has been working with me day in and day out in service of the patients, treating their low back pain and other pain syndromes. And this is the work which we are doing collectively. The pain team comprises of both boys and girls. And this is the picture before the COVID, when there were no masks and no face shields. I bow down my head in front of all my teachers and parents because of their teachings and blessing. I am here talking about management of low back pain. And I conclude by saying, we have not lost faith in God, but we have transferred it from God to the medical profession. So onus is on us to treat the low back pain and relieve the patients of pain. Thank you for your patient hearing.
That was quite an informative session. Despite being physically not present, Sir exerted so much to deliver this wonderful talk. Thank you so much. Next, we have a lecture on sacroiliac joint pain and management, which will be delivered by Dr. Amitesh Pathak sir from Integral Institute. Sir is an assistant professor in Integral Medical College. He is an ex-director and head of Department of Pain Medicine and Palliative Care, Chandan Hospital. His area of interest is endoscopic spine intervention, and he has a number of publications in national and international journals.
Thank you so much, the organizing team, Sarita Madam, Ajay Sir, Manish Boss. And it's really a privilege to come to KGMC once again. And it's always good to see a jam-packed like hall. We are not used to this. So it's very good. Actually, I'm very delighted to see so many like youngsters and students. Ma'am told anesthesiology and paramedics, both are there. So definitely, this is going to be a good interactive session for you. And you should be serious about pain now, because the DM course has also been started in pain medicine. In the IIMS Rishikesh, the second or third batch is going on. And another a good feather in our cap is like in Kanpur Medical College, the Department of Pain Medicine has already been started. So let's come to, as Sir has already explained the low back pain things, let's come to a specific thing, which is a sacroiliac joint dysfunction. Morning, sir. So let's go to the topic, that is sacroiliac joint dysfunction. And Coming to the epidemiology of the sacroiliac joint, of the altogether the chronic low back pain, if you go to the prevalence, it is around 16 to 30% of the incidence is a sacroiliac joint dysfunction. Near about 25% is the, if you say in a rough shell. They are more common in females because of the two factors. One is the shape of the pelvis, and other is the ligamentous laxity. This in the sacroiliac joint is a C-shaped. Usually, the articular surface is a C-shape or ear-shaped, and there irregularity in the between in the iliac bone, and this sacrum and the ilium, they somehow get an intense connection. That's why this joint, the sacroiliac joint, is a very stable joint. And add on to that, there are multiple ligaments attached to this joint. So that's why it is more stable joint, and that is more pronounced in case of male than in case of females. So this sacroiliitis is more commonly seen in the female patients. Now, if you go to the anatomy, this joint is formed by the superior and the outermost portion of the iliac bone in the medial portion, and the sacrum, S1, S2, and the upper part of the S3 sacral vertebra. So these form a true synovial joint. Why I'm saying it's a true synovial joint? Because there are few characteristics of a synovial joint. One is there is a joint cavity having a synovial fluid. Then their adjacent bones have ligamentous connection. Third is cartilaginous surface, which permit the movement, and their outer fibrous joint capsule. So it is a true synovial joint. There are powerful ligaments which support the joint, and they sharply limit the movement. So that's why you very rarely you will see there is any fracture around the sacroiliac joint. There are few ligaments which are like interosseous ligament. Interosseous ligament is a ligament which is between the oblique kind of ligament, which is between the S1 and S2 level. Then there are the stronger posterior sacroiliac ligament. There are stronger ligament, and then there are the thinner anterior sacroiliac ligament, and then there are some accessory ligaments. Like if you can see, pointer, yes. Then there are accessory ligament like sacrotuberous ligament or sacrospinous ligament or iliolumbar ligament. All these ligaments, they provide the very powerful support to the sacroiliac joint, and they sharply limit their movement. So this is the anterior sacroiliac. This is the anterior sacroiliac ligament. These are the anterior sacroiliac ligament between the S1 and S2 and the iliac bone. Then there are the posterior sacroiliac ligament. These all provide a very strong support to the sacroiliac joint. When you come across the sacroiliac joint innervation, they are posterior innervation and the anterior innervation. These are the posterior innervation. They derive from the lateral branches of the dorsal ramus of L4 to S3. So why this is important? Because when we do some interventions, we have to make out what we are going to do with. Then the anterior innervation is by the posterior ramus of L2 to L3 segment. Now, when most of you might have been to the pain clinic, and when a patient, you might have seen Sarita madam or Manish boss doing some examination and a patient lying down to rule out what is the cause of that low back pain. So while dealing with, you take a proper history, what kind of pain, where is the radiation, since how long the pain is there. Then you take some other history like, is there any history of fall and history of trauma? That is important in case of the sacroiliac joint. Then what are the treatment modalities they have already been taken. So whenever a patient comes and gives a history, like he has a low back pain और करवट बदलने में बहुत तकलीफ हो रही है, अक्सर आपके घरों में भी ऐसा होता होगा. जैसे आपके घर में किसी को, अगर आप घर में भी इसको डायग्नोज कर सकते हैं, वहाँ ट्रीट ना करें, पेन क्लिनिक लेकर आएँ. सो आप इस तरह से बोलते हैं कि कमर में दर्द है और आप पूछते हो कि किस वजह से दर्द हो रहा है, आगे झुकने में हो रहा है, हम ये पूछते हैं ना, आगे झुकने में, बैठ के उठने में, करवट बदलने में. सो वेरी स्पेसिफिकली दिस काइंड ऑफ पेशेंट थे, डॉक्टर साहब रात में सोते समय ना करवट बदलने में बहुत तकलीफ होती है. सो दैट एक क्वेश्चन मार्क आपके दिमाग में आना चाहिए कि इट कैन बी अ sacroiliac joint dysfunction. 94% of the patient, they come with a complaint of a buttock pain. हाथ रख के आते हैं. They say that I have a gluteal pain, and they say that if you ask further कि ये क्या पैरों में झिंझिनी लेके जाता है, they don't, most of the time they would say कि no, there is no tingling numbness. But sometimes, like in 70% of the cases, they can be associated lumbar pain. ऊपर भी थोड़ा सा पेन होता है, थोड़ा सा पैरों में भी जा रहा है, और पैरों में भी they specifically say lateral aspect of the thigh or the back of the thigh. So, और groin pain के साथ भी हो सकते हैं. These are the classical symptoms. You don't need to do any X-ray or MRI to diagnose sacroiliitis. So then you do some, you must have seen, if you have been to the pain clinic in your institute, you must have seen few of these tests being done in the pain clinic. So these are few of the tests for the sacroiliac joint. We don't do routinely all the tests. We do Faber's test or Patrick's test. So there are a list of tests like Yeoman test or Patrick test or Ganslen's test, sacroiliac shear test, Hibbs test. So these are this is a Yeoman test. What is done in this? Patient lies prone. We have to grasp the lower leg and passively flex the knee and try to extend the hip. जैसे ही हम करेंगे उसको exactly sacroiliac joint पे he will have pain. So if the pain indicates stress on the sacroiliac joint or the ligament stretching. Very classical test. घर पे भी आप कर सकते हो, ज़्यादा नहीं करना. This test is routinely done in our pain clinic. This is the Faber's test or Patrick's test or figure 4 sign test. If you do that, you flex the knee. Faber's is flexion, abduction, and external rotation. Flexion, you flex the knee, external rotate, and abduct the hip. If the pain is elicited on the ipsilateral side, same side अगर pain हो रहा है, anteriorly, so it suggests the hip joint involvement. But if the pain is elicited on the contralateral side, posteriorly, you can make out a diagnosis of sacroiliitis. Similarly, this Ganslen's test, in this test is performed with the patient lying supine. Patient is asked to come towards the edge of the table, edge of the couch or table. The patient is asked to lie supine and the hip joint is maximally flexed on one side, and then the opposite hip is extended. And then you put a pressure over there and the patient will have the pain on the ipsilateral side. So this is Ganslen's test. Another is Hibbs test, in which the patient lies prone, leg is flexed, then move the leg outward to internally rotate the hip. Once you do that, if the pain in the SI joint indicates a sacroiliac joint lesion, if there is a pain in the hip, it is a hip joint lesion. So you can differentiate between a hip joint like dysfunction or a sacroiliac joint dysfunction. If you do one or two or three of this kind of a test, you can rule out whether it's a sacroiliitis or the sacroiliac joint dysfunction pain, or it is the involvement of the hip joint. Another is, we don't do this. This is a positive pelvic pain provocation test. The test was positive when the patient felt a familiar well-localized pain in the gluteal region. Now we come to the differential diagnosis. Whenever a patient of a sacroiliitis or this kind of a pain, like patient saying I have low back pain, or in the gluteal pain which is going to the back of my thigh and it is non-radiating, so we make a differential diagnosis. Usually this kind of a patient, usually a younger patient and a female in the range of 20 to 30 years, then we think of, is it a spondyloarthropathy? Is it an ankylosing spondylitis? For that you need to ask some more question like, does the patient has a history of morning stiffness or some other joint involvement or reactive arthritis? Other can be if L4, L5 region, if you feel the patient is complaining of the lower back pain in the L4, L5 region, you can rule out lumbar nerve root compression as well. For that you need to get an X-ray done, you need to do some more test and get an MRI done. Or there can be a myofascial pain or a piriformis syndrome. These are few entities. I'm not going into the detail of all these. We keep all this in our mind to make a diagnosis of sacroiliitis. How do we treat? Simple. We start with the conservative treatment with NSAIDs and all, or some oral steroids, do some physical exercises. We do that routinely, but many a times, like 20 to 30% of the times, in spite of doing all these things, the patient is not relieved. Patient is coming to your OPD day and again. Then you have to think of, you have to intervene with interventional procedures. So what are these interventional procedures? What we do for the sacroiliitis? There are certain sacroiliac SI joint intervention which we normally do, like diagnostic injections, corticosteroid injections, hyaluronate injection, or the joint innervation with radiofrequency ablation. These all things routinely we do. How do we do? We take the patient on the OT, and then under C-arm guidance we do. The below one is a picture of a C-arm, where you try to align the SI joint, anterior and posterior SI joint, and you make a straight line. Try to make a straight line. If you are doing on the right side, C-arm should be tilted a bit towards the left side to make it a straight line. And once it is done, this is how you make a single straight line alignment of a SI joint, and you put the needle, you do under fluoroscopy guidance, and what we do, we rotate the C-arm to 5 to 10 degree on the on the both side, from this side and that side both. You try to make sure that your needle is exactly in the SI joint. Another way of doing it that I learned from Dr. Ashu Jain, and he told rather than shifting the C-arm, you shift the hip towards this side and this side. So this is how you do. It's almost like 5 to 10 degree. This is how we do. This is the first to fix the SI joint in a single plane. Then you tilt towards one side, then you tilt towards the other side. Make sure your needle is inside the joint. Then you put the die inside, and if you get this is an excellent picture. The die is spreading almost in the SI joint. When you're confirmed with this, you give the drug. Then, if there are some some kind of a patient who, in spite of giving the corticosteroid injections at the SI joint, they don't get relieved, then the last resort will be radiofrequency ablation, and it is being done at the radiofrequency ablation. Either it can be done as a conventional radiofrequency where 80 degree temperatures is used, or you can do a cool radiofrequency and that 60 degree temperature is used. So cooled RF procedure is done at the S1, S2, S3 level and the L5 level. And there are few evidences for the interventional pain procedures in SI joint. Therapeutic intra-articular injection, they have a level evidence of 1B+. Radiofrequency treatment of the rami dorsalis and lateralis is 2C+. Pulse RF is 2C+. Cooled RF is 2B+. So level of evidence is fairly good. So to summarize, the SI joint is responsible for around 16 to 30% of all the chronic low back pain, around 25%. Currently, the majority of the scientific evidence points toward the intra-articular SI injection. I don't say they give short-term improvement, they give a good improvement. Like a patient having a severe kind of a pain, the patient cannot move on the bed. Next day itself, the patient will walk on his feet. If the latter fails or produce only short-term effects, sometimes it can happen, then a combination of cooled and the conventional RF treatment can be provided. Evidence is 2B+. When this procedure cannot be done, then RF procedure targeted L5 ramus and the rami lateralis of S1, 2, 3 may be tried. This is my institute where I'm working right now. This is the Integral Institute of Medical Sciences. I have started the pain, spine and pain clinic department there, and I'm running it well. Thank you so much. Sure.
Because I have done cold RF, I have done conventional RF, and what I found after steroids, probably the cryo that is.
Definitely. Thank you, sir.
Thank you so much, sir, for such an amazing session. Next, we have a session on overview of chronic pain management, which will be dealt by the living legend of pain medicine, Dr. Anil Agarwalser. Sir is a prominent name in this field. He is a pioneer in pain medicine who has established it to a completely new level. Sir needs no introduction, but still it's a formality to read out his CV. So I'll be reading it out. Sir is a designated senior consultant and head in the Department of Anesthesia, Apollo Medics Hospital, Lucknow. Awards instituted in his honor are ISA UP started a Professor Anil Agarwal Best Researcher Award in 2021. He has been awarded with the Lifetime Achievement Award by ISA UP State in 2021. He is an eminent medical teacher award that is awarded by IMA 2017. ISA Bhopal Award for Academic Excellence in the year 2013, Excellence and Leadership Award in Palliative Care among SAARC countries in the year 2012. Sir is a president of Society of Ultrasound and Anesthesia. He is past president of Indian Society for the Study of Pain, Indian Society of Pain Clinicians, ISA UP and Lucknow City branch. He has been organizing secretary for ISSPCon 2007 and ISACon 2010. He has about 217 publications in his name, and his area of interest are pain and palliative care. Sir.
Good morning, everybody, and thanks for such a nice introduction. And see, actually, I don't know I deserve it or not. Thank you, everybody. It's nice to see the hall full after such a long gap of period of from COVID. We were suffering from COVID, and for last 2 years, we have been meeting in groups of 6, 8, 10, and 20, at maximum 20 people. So it's a lovely feeling, and I'm not talking to my computer or laptop. I'm talking to a live audience. Thanks, organizers, for this opportunity. Over the next 20 minutes or so, I shall be talking about overview of chronic pain management. It is actually a very, very vast topic to cover, and I shall try and do justice with that. Year 20, the current year by IASP is the Society of Pain Clinicians or Physicians throughout the world, and it is a big organization, and this year it has designated this year as for the cause of translating pain knowledge into practice. So this is the agenda of this year, and I think this conference would be a part in the same direction. Burden of pain is immense, as we all know. Treatment varies depending on the type and the nature of the pain which the patient is suffering. And opioids have a role, and more so it has a pivotal role in the management of moderate to severe acute pain. Acute pain is postoperative pain, and management of cancer pain. So these are two pains where opioids have a major role in management of these pains. There is another pain that is known as chronic non-cancer pain, and here the role of opioids is debatable. So coming up to types of pain. In the acute pain, it could be either because of the trauma, which could be surgical, could be because of the burns, bone fractures, labor pain, or intraoperatively and postoperative pain. So these are the causes of acute pain. Then another causative factor could be cancer pain. And the third, which I shall be concentrating on today, is chronic non-cancer pain. So why should we treat chronic non-cancer pain, that which can also is also known as CNCP, you can call it? Because treatment of pain is a basic human right, as we all know. And what is basic human right? What is the human rights? Human right is something which every living human being has as regards to their few fundamental rights. Internationally, which everybody is entitled to, like food, shelter, and health care. Okay, so it is part of that. So that is why we need to treat our patient's pain. Then physicians are obliged to treat pain. You have an obligation to treat pain, and this has been said by American Medical Association, published in JAMA later. And then again, we as doctors have an ethical duty to manage our patient's pain. So, and there are few rights mentioned by the International Society of Health, and they haven't, as of now, they have not mentioned pain as a part of it, but they have stated that we have to take care of health of our patients. And in health encompasses pain for sure. I'm sure nobody has a doubt on that. So we have to take care of our patient's pain. It could be of acute nature, it could be cancer pain, it could be non-cancer chronic pains. So, as we all know that pain is a common symptom of numerous medical problems, and usually presents as, it indicates basically कि कहीं पे somewhere there is a tissue trauma occurring and it is unpleasant. In the initial phase, pain is protective in nature. It has got use. It is useful. उससे होता क्या, जब पेन होता है तो आप किसी आर्म में चोट लगी, आप रेस्ट दोगे उसको, उसकी हीलिंग जल्दी होगी. So that is how it helps in healing. And another way it helps is, because of the pain, you consult some physician, you go to the doctor, get the treatment. Your problem is, they find out what is the problem and you get the treatment, and that is how it helps you in getting the treatment. So that is, it is protective. However, when pain becomes chronic, relentless, long-lasting, everlasting, then it is associated with so many issues like mental issues, physical effects, and it becomes destructive. It is of no use. It has to be treated. There is more justification of treating of this kind of pain. But जो acute pain की मैं बात कर रहा था, अगर उसको भी हम properly treat नहीं करेंगे तो it converts into chronic pain. वो जब chronic बन जाएगा तो फिर chronic का अपना problem है, जो मैं भी बात कर रहा था कि relentless है, destructive है, कोई usefulness नहीं है इसका, mental and physiological, psychological side effects हैं इसके. So it has to be treated. So we have to take good care of our patient's pain. इसमें आज we have got audience from workshop जो attend कर रहे हैं, and apart from that, उतने ही है. तो you have got a huge gathering. Junior residents. Okay. So maybe it could be worthwhile, जो मैं आगे बात कर रहा हूँ, maybe for the junior residents of the department. IASP ने, जिसकी मैं बात कर रहा था, सोसाइटी ने 1979 में पेन को डिफाइन किया था, and this is the definition which they gave, कि it is an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage, or described in those terms. अगर इसको देखेंगे तो इसमें limitations क्या थी इसको change किया गया आगे. Limitations थी कि इसमें कहा कि describe करना है आपको पेन को. That means जो describe नहीं कर पाएगा तो मतलब उनको आप ले नहीं पाओगे. That means you cannot include, this did not include infants या elderly people जो कि इसको communication उनका चला गया है, coherent नहीं है, they will not be able to communicate. तो इन patients में ये limitation था कि इस definition से आप पेन को define ही नहीं कर पा रहे थे कि वो पेन में है, ये भी आपको नहीं पता चल रहा था. Then ISP ने 2020 में नई definition लेके आए. Almost same definition है with few changes but very relevant changes. And उन्होंने कहा कि जो मैंने रेड में मार्क किया है, ये ऐड किया था उन्होंने डेफिनेशन में, पुरानी डेफिनेशन पे रेड से जो हाईलाइटेड है, दिस हैज बीन एडेड, कि रिजेंबलिंग दैट एसोसिएटेड विथ, ये ऐड किया गया था, और लास्ट का पार्ट इन्होंने रिमूव किया, और डिस्क्राइब्ड इन टर्म्स ऑफ सच डैमेज. तो डिस्क्रिप्शन वाला पार्ट तो उन्होंने निकाल दिया. एंड साथ में दो ये दिए थे 6 की नोट्स दिए थे जिसको इसको और क्लैरिफाई करने के लिए. सो दिस इज द करेंट डेफिनेशन ऑफ न्यू डेफिनेशन ऑफ which is approved by ISP in 2020. कि पेन इज ऑलवेज अ पर्सनल एक्सपीरियंस. हर आदमी का इंडिविजुअल का एक पर्सनल एक्सपीरियंस होता है दैट इज इन्फ्लुएंस्ड टू वेरिंग डिग्रीज बाय एनवायरनमेंट. कहाँ पे रह रहा है, क्या पढ़ा है, साइकोलॉजिकल बैकअप क्या है, बायोलॉजिकल बैकअप क्या है उसका. देन पेन एंड नोसियोसेप्शन दे आर डिफरेंट. अगर किसी को नोसियोसेप्शन नहीं हो रहा तो इसका मतलब ये नहीं कि पेन नहीं हो सकता. पेन के और भी रीजंस होंगे, हो सकते हैं. ओके. फिर लाइफ में जो भी एक्सपीरियंसेस एनकाउंटर करता है आदमी, जो हम लोग लाइफ के एक्सपीरियंसेस को भी पेन को कैसे परसीव करेगा उसको मॉडिफाई करता है. सो दैट इज ऑल्सो देयर. एंड जो पेशेंट जो रिपोर्ट करते हैं पेन को, एक्सपीरियंस करते हैं, दैट हैज़ टू बी रेस्पेक्ट. उसको आपको मानना है, उसको बिलीव करना है. ऐसा नहीं है कि पेशेंट कह रहा है यार वो तो ऐसे ही बोलते रहते हैं. नहीं, ऐसा नहीं है. जब पेशेंट कह रहा है तो हमको उसको मानना पड़ेगा, उसको मानना चाहिए हमें. ऑल्दो पेन यूजुअली सर्व्स एडेप्टिव रोल. एडेप्टिव रोल होता है कि पेन हो रहा है, आपने मेजर्स लिए जिससे कम कर लिया उसको. बट इट मे हैव एडवर्स इफेक्ट्स. और भी सिस्टम्स पे इसका एडवर्स इफेक्ट्स हो सकता है. फंक्शनल, सोशल, साइकोलॉजिकल वेलबींग को भी इफेक्ट कर सकता है. एंड वर्बल डिस्क्रिप्शन इज नॉट ओनली जिस वे में कि पेशेंट कम्युनिकेट करता है, देयर आर मेनी अदर वेज ऑफ कम्युनिकेशन ऑफ दिस पेन. सो ये 6 पॉइंट्स को, उस डेफिनेशन को सब्सटेंशिएट करने के लिए इन्होंने दिए. सो कमिंग ऑन टू क्रॉनिक पेन नाउ. पेन परसिस्टिंग, इसके क्रॉनिक पेन के बहुत सारे डेफिनेशंस हैं, कम से कम काफ़ी हैं, 3, 4, 5 हैं. तो उनको 2 या 3 मैं आपसे शेयर कर रहा हूँ. एक तो पहला है कि पेन दैट परसिस्ट बियॉन्ड द एक्सपेक्टेड पीरियड टाइम ऑफ हीलिंग. कि सर्जरी करते हैं, कोई भी सर्जरी हुई, उसके बाद डिपेंडिंग ऑन द सर्जरी आप एक्सपेक्ट करते हो कि 10 दिन में ठीक होगा या 15 दिन में ठीक होगा या 20 दिन में ठीक होगा. इफ़ हीलिंग उस पीरियड में नहीं होती और पेन परसिस्ट करता है तो उसको क्रॉनिक पेन डिफाइन कर सकते हैं. या पेन जो कि क्रॉनिक पेन जो कि विच इज़ अकम्पनीड बाय डिजीज प्रोसेस. कोई डिजीज प्रोसेस है अंडरलाइन, दैट कैन बी कॉज ऑफ क्रॉनिक पेन. अगेन ISP का जो डेफिनेशन है, उन्होंने डेफिनेशन डिफाइन किया था कि इफ पेन दैट लास्ट मोर देन 3 months. Chronic pain is persists long after it can serve any useful purpose. जैसे मैंने कहा था ना, acute pain है, उसकी relevance है, बताता है आपको कि कहीं पेन हुआ, आप डॉक्टर को जाते हो, ट्रीटमेंट लेते हो. क्रॉनिक पेन में इट डजेंट हेल्प यू दैट मच. सो कोई फंक्शन नहीं है, प्रोटेक्टिव नहीं है, डिस्ट्रक्टिव है. अगेन रिपीट कर रहा हूँ इस चीज़ को. एंड ये नो लॉन्गर इज जस्ट सिम्टम ऑफ इंजरी. की इंजरी हुई नहीं हुई ये भी पता नहीं, कि सेकेंडरी टू इंजरी होगा, जरूरी नहीं है, और डिजीज. बट इसको ये इटसेल्फ एक मेडिकल प्रॉब्लम की तरह मानना चाहिए इन इट्स ओन राइट. एंड इट इज ए सिंड्रोम विच इज कैरेक्टराइज्ड बाय फिजिकल पेन हो सकता है, डिसेबिलिटी हो सकती है, इमोशनल डिस्टर्बेंस हो सकता है पेशेंट को, सोशल विड्रॉल हो सकता है इन पेशेंट्स में. एंड ये सब या एक 2 3 चीज़ें हो सकती हैं इनमें से, या चारों हो सकती हैं, और ये सब एक दूसरे को साथ होकर एक दूसरे को इन्फ्लुएंस भी कर सकती हैं. सो इट इज़ ए कॉम्प्लेक्स थिंग. इट इज़ ए क्रॉनिक पेन इज़ ए सोर्स ऑफ फिजिकल पेन. कहाँ से ओरिजिनेट हो रहा है इसका जरूरी नहीं कि पता चल पाए कि क्रॉनिक पेन का क्या कॉज है, कहाँ से ओरिजिनेट कर रहा है. तो इट इज़ डिफिकल्ट टू फाइंड आउट. एंड बहुत ज़्यादा ऐसा नहीं कि हमको फिक्स ही करना है कि बायोमेडिकल कॉज ढूंढना है कि नहीं मिलेगा तो हम ट्रीट नहीं करेंगे. ऐसा नहीं है. क्रॉनिक पेन है, इसको ट्रीटमेंट की ज़रूरत है. वी नीड टू ट्रीट दिस पेन. एंड फैक्टर्स रिस्पॉन्सिबल, जैसा हमने पहले भी बात करें कि कुड बी क्रॉनिक पेन का बायोलॉजिकल कॉज हो सकता है, साइकोलॉजिकल हो सकता है, सोशल हो सकता है, ऑल 3 हो सकते हैं, एक साथ भी हो सकते हैं. So coming to treatment, how do we go ahead? बहुत कॉम्प्लेक्स है तो ट्रीटमेंट तो आसान होना नहीं है. इट्स क्लियर. सो बहुत सारे ट्रीटमेंट ऑप्शंस हैं. अगेन इशू है, कुछ कम इन्वेजिव हैं, कुछ मोर इन्वेजिव हैं, फिर कुछ कम लेस इन्वेजिव हैं. एक तो बायोमेडिकल ग्रुप है जो पहला अगर आप देखेंगे साइड में, दैट इज पॉइंटर है क्या? तो एक्चुअली बहुत आप देख सकते हो लेफ्ट साइड ऑन द स्क्रीन पे ना कि बायोमेडिकल ट्रीटमेंट है, राइट साइड ऑन द स्क्रीन पे मैंने डाले हैं बायोफिजियोलॉजिकल जो ट्रीटमेंट ऑप्शंस हम लोगों के पास हैं. एंड दे आर कितने सारे हैं, बहुत सारे हैं. इनको बात करेंगे तो आप, आई एम प्रीटी श्योर आप सब सो जाओगे. कुछ तो सो भी रहे हैं अभी भी. ओके. तो बेसिकली क्या है कि जैसे मैंने बताया बहुत सारे सिस्टम्स इन्वॉल्व हैं, बहुत तरह का है. तो मल्टी मॉडल अप्रोच लेनी पड़ेगी आपको इसमें. मल्टी डायमेंशनल मल्टी स्पेशलिटी अप्रोच लेनी पड़ती है. एंड इट इज़ ऑलवेज एडवाइजेबल कि कभी भी कोई भी ट्रीटमेंट करते हैं कि लेस इन्वेजिव से चल के मोर इन्वेजिव की तरह जाना चाहिए. मतलब दैट इज़ कॉमन सेंस. तो अगर जहाँ पैरासीटामॉल दे के मेरे मरीज का पेन ठीक हो जाता है अगर, तो वी मस्ट ट्राई पैरासीटामॉल. हम इंटरवेंशनिस्ट हो सकते हैं, बहुत बड़े इंटरवेंशनिस्ट हो सकते हैं, बट स्टिल गिव पेशेंट अ चांस टू रिस्पॉन्ड विद मिनिमल इन्वेजन. तो अब जैसे लेस इन्वेजिव वाले बायोमेडिकल ट्रीटमेंट्स में 3 तरह के होते हैं. एक तो फार्माकोलॉजिकल ट्रीटमेंट दे सकते हो, जैसे हमने कहा पैरासीटामॉल है, टॉपिकल एनाल्जेसिक्स है, ओरल एनाल्जेसिक्स हैं, नर्व एडजुवेंट एनाल्जेसिक्स देते हो आप. इसके बाद जब और आगे चलते हैं तो मोर इन्वेजिव की तरह जाएंगे, तो फिर हमें नर्व इंजेक्शन ब्लॉक्स दोगे जिनको ज़रूरत पड़ेगी तो, या वी देन टुवर्ड्स इट कुड बी मोर सर्जिकल देन कि इंट्राथीकल इम्प्लांट्स देना है, या नर्व सेक्शन करते हैं जो नर्व पेन को कैरी कर रही है, आपने उसको ब्लॉक कर दिया लोकल एनेस्थेटिक दे के, या बर्न कर दिया, डैमेज कर दिया, तो पेन नहीं जाएगा ऊपर ज़्यादा. देन सिमिलरली स्पाइनल कॉर्ड स्टिमुलेशन है, परक्यूटेनियस इलेक्ट्रिकल नर्व स्टिमुलेशंस हैं, ट्रांसक्यूटेनियस है, इस तरह के. एंड देन अगेन लेस इन्वेजिव में जैसे ट्रांसक्रैनियल स्टिमुलेशन. इसके साथ में ऑन द राइट साइड देखें तो फिर बाकी चीज़ें भी करनी होंगी. दैट इज़ फिजियोथेरेपी हैज़ ए वेरी इंपॉर्टेंट रोल इन द मैनेजमेंट ऑफ कैंसर पेन. मतलब ठीक ही, आई डोंट थिंक सो कोई, मतलब बहुत कम पेशेंट्स होंगे, 10-15 पेशेंट्स होंगे, % हो सकते हैं जो कि फिजियोथेरेपी नहीं करो, आपको हमें ब्लॉक दे देंगे या हम कुछ दे देंगे, ठीक हो जाएंगे. क्यों? क्रॉनिक पेन के पेशेंट्स में फिजियोथेरेपी हैज़ ए वेरी इंपॉर्टेंट रोल. सिमिलरली ऑक्यूपेशनल थेरेपी है, कॉग्निटिव बिहेवियर थेरेपी आप लोगों ने सुना होगा, इट हैज़ गॉट लॉट ऑफ रोल. मैं उस पर बात करूँगा. एंड मे बी एक्सेप्टेंस एंड commitment therapy. So they have got but all of these have to be given simultaneously, some of them at least. ये मैंने बात किया कि डाइवर्स है. कोई प्रॉब्लम क्या है क्रॉनिक पेन में, कोई बहुत बड़े मेजर गाइडलाइंस नहीं है. जैसे अगर एक्यूट पेन का आप देखते हो तो गाइडलाइंस हैं. कैंसर पेन के मैनेजमेंट के लिए WHO ने निकाला, WHO लेटर निकाला कि कैसे कैसे, बट इसमें कोई स्पेसिफिक गाइडलाइंस नहीं है, अवेलेबल नहीं है, बनाना मुश्किल है. मे बी ओवर अ टाइम कभी निकल के आए आगे. देन इशू है कि बहुत सारे ऑप्शंस हैं. जब बहुत सारे ऑप्शंस हैं तो उन पे उनका एविडेंस उतना अभी स्ट्रांग नहीं है कि कौन सी चीज़ कहाँ पे काम करती है या नहीं करती है. तो एविडेंस भी, जो भी ऑप्शंस हैं उनके एविडेंस बहुत स्ट्रांग नहीं है. ओपियाइड्स का रोल भी उतना बहुत लिमिटेड है. ऐसा नहीं है कि जैसे कि एक्यूट पेन में था, या खास करके कैंसर पेन में तो बहुत ही ज़्यादा था, तो क्लियर है वो भी नहीं है इशू. एंड ओके, सो ट्रीटमेंट इज ए मिक्स ऑफ मेडिकल, फिजिकल एंड साइकोलॉजिकल कंपोनेंट्स. नंबर 1, पेशेंट को जो है ही और शी शुड रिसीव मल्टी डिसिप्लिनरी ट्रीटमेंट. एक सिंगल पर्सन, सिंगल फिजिशियन कैन नॉट ट्रीट इन मोस्ट ऑफ द केसेस दीज पेशेंट्स. जैसे WHO ने लेटर दिया था ओपियाइड कि कैसे कैसे यूज़ करना है, कि अगर पेन लोअर होगा, कम इंटेंसिटी का होगा, तो आप नॉन ओपियाइड से ट्रीट करेंगे. फिर स्टेप 2 पे जाएंगे जब नॉन ओपियाइड से हमने दिया, जैसे लाइक पैरासीटामॉल से कहते हैं कि पैरासीटामॉल इज़ दी बिगनिंग अगर पहले सबसे पहले पेशेंट आता है उसको पेन हो रहा है, उसको पैरासीटामोल दीजिए, इट इज़ द सेफेस्ट एनाल्जेसिक. आपने पैरासीटामोल दिया, पैरासीटामोल से पेशेंट नहीं रिस्पॉन्ड किया, देन यू मूव ऑन टू स्टेप 2. स्टेप 2 में आपने वीक ओपियाइड्स ऐड करेंगे, इसके साथ में एडजुवेंट्स ऐड करेंगे. अगर उससे भी रिस्पॉन्ड नहीं हो रहा, पेन फिर भी नहीं ट्रीट हो रहा प्रॉपरली, देन यू हैव टू गो ऑन टू एंड स्विच ऑन टू थर्ड स्टेप, दैट इज एडिंग स्ट्रॉन्ग ओपियाइड्स. तो ये है. फिर इसमें आता है इंटरवेंशन, कि दैट मीन्स इंटरवेंशन का भी तो रोल है. तो इंटरवेंशन हमें कब करना है? तो एक थॉट आया कि लोगों ने कहा कि इंटरवेंशन को फोर्थ स्टेप मानते हैं हम. तो उसका भी प्रॉब्लम क्या है उसमें भी? जब आप उसको फोर्थ स्टेप बना लेते हो तो दैट मीन्स कि जब थर्ड स्टेप को रिस्पॉन्ड किया कर लिया, एग्जॉस्ट हो गया, एक तो तब तक पेशेंट को वेट करना पड़ेगा, तभी तो करेंगे क्योंकि बाय द स्टेप हमको एग्जॉस्ट करनी है, फर्स्ट स्टेप, फिर सेकंड स्टेप, फिर थर्ड स्टेप. दूसरा कि आपको तब तक वेट करना पड़ेगा तो डिले हो सकता है, जो कि पेशेंट जहाँ पे ज़रूरत हो आप नहीं दे पा रहे हो उसको. दूसरा, जब फोर्थ स्टेप आपने डेजिग्नेट कर दिया तो दैट मीन्स कि इसको करना ही करना है. अगर ये पेन रिस्पॉन्ड नहीं किया था थर्ड स्टेप पे, हमको पता है इंटरवेंशन से भी रिस्पॉन्ड नहीं होगा वो पेन, बट हमें करना है क्योंकि WHO ने लेटर में बोला है कि फोर्थ स्टेप है. सो दैट इज़ अनदर प्रॉब्लम विद हैविंग इसको ऐड करने के लिए इंटरवेंशन को एज फोर्थ स्टेप. तो इन्होंने इसको इतने डिस्कशन के बाद WHO ने कहा छोड़ो इसको, फंसे हैं इसमें, फंस गए, तो वी लीव इट हियर. हम इसको एक अम्ब्रेला की तरह छोड़ देते हैं इंटरवेंशन को, कि इंटरवेंशन जब आप ज़रूरत समझें तब आप कर लीजिए. अपनी स्किल देख लीजिए कि हम कितने स्किल्ड हैं, अवेलेबिलिटी कैसी है इक्विपमेंट की, इंफ्रास्ट्रक्चर की, पेशेंट की विलिंगनेस की, अफोर्डेबिलिटी की, एंड देन यू कैन डू इट द वे यू वांट. सो दैट इज हाउ. तो ये आई हैव कवर्ड दिस. Regarding availability of morphine, just to highlight कि it is a big issue in our country. Things काफ़ी better हो रही हैं, but issue क्या है कि ओपियाइड के लिए, पेन के लिए, जैसे मैंने कहा एक्यूट पेन के लिए में ज़रूरत होती है काफ़ी बार. कैंसर पेन में मॉर्फिन देना ही देना है, WHO का रिकमेंडेशन है, अगर मतलब इट इज़ द मेन स्टे ऑफ ट्रीटमेंट इन कैंसर पेन. तो वहाँ पे we have to ensure the availability of morphine, but the issue is इसका divergence. तो बैलेंस करना कि हमने अगर रूल्स इजी बना दिए, इनिशियली क्या हुआ, जब मॉर्फिन की ज़रूरत थी तब लोग डाइवर्जेंस बहुत होता था इनिशियली, तो गवर्नमेंट ने बहुत स्ट्रॉन्ग रूल्स बनाए जिससे कि मॉर्फिन ना मिल पाए किसी को, कम से कम मिसयूज़ ना हो पाए. उनका एजेंडा था कि मॉर्फिन का मिसयूज़ ना हो, डाइवर्जेंस नहीं हो. इतने स्ट्रिक्ट रूल्स बना दिए कि अब मरीज को भी नहीं मिल पाती थी, डॉक्टर को भी नहीं मिल पाती थी. सो इतना कम्बरसम प्रोसेस था, मैं लूँगा नहीं, इतना टाइम नहीं होगा. तो क्या हुआ, तो फिर सब्सिक्वेंटली लेटर डेट पे फिर नए गाइडलाइंस निकाले गवर्नमेंट ने, और उसमें उन्होंने ईज आउट की ये सिचुएशन. उन्होंने उनका एजेंडा प्रेमाइस जो नए गाइडलाइंस का था कि नीडी पर्सन्स को मॉर्फिन मिल जाए. डाइवर्जेंस के लिए रोकने की कोशिश करेंगे, लेकिन जो गवर्नमेंट की ये भी रिस्पॉन्सिबिलिटी है ना कि जो मरीज हमारे हैं, सफरर्स हैं, जिनको नीडी हैं, उनको ह्यूमन राइट है उसका, तो उसको अवेलेबिलिटी इंश्योर करनी है. तो नाउ दे हैव चेंज द गाइडलाइंस एंड दे हैव मेड इट मच ईजियर. इसका दूसरा आप एक साइड देखेंगे कि देखिए अब यूएस का आजकल रिसेंटली सुना होगा, पढ़ा होगा आप लोगों ने, कि यूएस में कितनी डेथ्स हो रही हैं बिकॉज ऑफ डाइवर्जेंस, बिकॉज ऑफ इजीली एक्सेस है वहाँ पे मॉर्फिन की, ओपियाइड्स की. तो वो खाते हैं, मज़े के लिए खाते हैं, बिल्कुल मतलब फाइनल डेस्टिनेशन पर पहुँच जाते हैं पहली बार में. सो दैट इज़ तो इट इज़ अ टफ जॉब कि कितना बैलेंस करें, कैसे बैलेंस करें. एक तीसरा एस्पेक्ट इसमें और आता है कि ये तो हमारे नीडी पेशेंट्स की हम लोग बात कर रहे हैं. फिर एक आता है ऑप्शन कि जो पेशेंट्स हैं ओपियाइड लेके, मिसयूज़ करके, दे हैव बिकम एडिक्ट, उनकी सेफ्टी और सिक्योरिटी भी इंश्योर करनी है गवर्नमेंट को, तो उसके लिए अलग से प्रोविज़न करना है. सो इट इज़ रियली अ टफ थिंग. तो ये पुराना जब इनका गाइडलाइंस था तो ऐसा था कि आपको इधर से एक साइड से अगर दूसरी साइड जाना तो यू कैन नॉट गो, सक्सीड नहीं करोगे आप, घूमते रहोगे वहीं रह जाएंगे आप अल्टीमेटली। तो नए गाइडलाइंस 14 में निकाला था उन्होंने, एक टनल बना दी रास्ते से, सो दैट यू कैन गो थ्रू एंड गेट द मॉर्फिन रिक्वायर्ड फॉर योर पेशेंट्स। एंड देन देयर गाइडलाइंस की कौन रख सकता है, रजिस्टर्ड मेडिकल प्रैक्टिशनर कौन है, और कौन रजिस्टर्ड RMI होता है एक, RMI इज रजिस्टर्ड मेडिकल इंस्टीट्यूट। रजिस्टर्ड मेडिकल इंस्टीट्यूट वो है जो कि मॉर्फिन अपने पास स्टोर कर सकते हैं, रख सकते हैं। रजिस्टर्ड मेडिकल प्रैक्टिशनर एक टर्म होता है इसी में, कि जो मॉर्फिन प्रिस्क्राइब कर सकता है। मॉर्फिन प्रिस्क्राइब कौन कर सकते हैं, या तो इधर डॉक्टर्स कर सकते हैं या डेंटल सर्जन्स कर सकते हैं। दो लोगों को उन्होंने कहा है, एग्री किया गवर्नमेंट ने, बट दे शुड हैव ए ट्रेनिंग इन मैनेज प्रिस्क्रिप्शन ऑफ मॉर्फिन, हाउ टू प्रिस्क्राइब मॉर्फिन, एंड मॉर्फिन से रिलेटेड जब साइड इफ़ेक्ट्स होते हैं, एडवर्स इवेंट्स होते हैं, उसको मैनेजमेंट करना आना चाहिए, उसकी ट्रेनिंग होनी चाहिए उनके पास। ट्रेनिंग की ड्यूरेशन क्या होनी चाहिए अभी इस पे उन्होंने कमेंट नहीं किया, सो दैट इज अगेन ए ग्रे एरिया। टॉपिकल एनाल्जेसिक्स का रोल है इसके क्रोनिक पेन मैनेजमेंट में। फेंटेनिल बुप्रेनोर्फिन पैचेस यूज होते हैं, काफ़ी करे जाते हैं, एंड दे हैव गॉट लेस साइड इफेक्ट्स एज कंपेयर टू ओरल मॉर्फिन। Buprenorphine, they have found that in variety of conditions it has been used patches, like in management of osteoarthritis, low back and neuropathic pain. Similarly, lidocaine patches वगैरह भी यूज़ किए गए हैं, and localized pain, इसका absorption नहीं होता, सब ट्रांसक्यूटेनियस absorption बहुत कम होता है, इसलिए उतने इफेक्टिव नहीं है, बट इनको बेसिकली पेरिफेरल न्यूरोपैथिक पेन में, पोस्ट हेपेटिक न्यूरल्जिया के पेशेंट्स में लिडोकेन पैचेस का काफ़ी इफेक्टिव रोल पाया गया है। रोल ऑफ इंटरवेंशन में आई हैव कवर्ड। इंटरवेंशन अगर करना है, अगर स्किल है, फैसिलिटीज़ हैं, तो जल्दी करना चाहिए। तब ये नहीं कि फोर्थ स्टेज के लिए, फोर्थ स्टेप के लिए वेट करेंगे, बिकॉज आपको फेवरेबल एनाटॉमी मिलेगी, आप कर पाओगे, रिस्पॉन्स अच्छा होगा, तो पेशेंट की क्वालिटी ऑफ लाइफ अच्छी हो जाएगी, एनाल्जेसिक कंजम्पशन कम हो जाएगा। तो अगर सब कुछ चीज़ें फेवरेबल है तो जल्दी करना चाहिए आपको। स्पाइनल कितना टाइम है मेरे पास? टाइम हो गया? टाइम है, अच्छा। स्पाइनल कार्ड स्टिमुलेशन के लिए था कि एक्सपेंसिव मॉडलिटी है, बहुत एक्सपेंसिव मॉडलिटी है। हम लोग, मैं PGI में था तो PGI में तो नहीं कर पाया, बट अब मैं जहाँ पे हूँ मेरे को लगता है यहाँ पे आई शैल बी एबल टू कुछ न कुछ पेशेंट्स कर पाऊँगा स्पाइनल कॉर्ड स्टिमुलेशन के या इंट्राथीकल पंप्स के। सो ये भी मॉडलिटी है जो कि स्पाइनल कॉर्ड, ये न्यूरो मॉड्यूलेशन के प्रिंसिपल पे काम करती है और गेट कंट्रोल थ्योरी पे बेस्ड है। यहाँ पे एपिड्यूरल स्पेस में प्लेस करते हैं आप इसको डोर्सल हॉर्न के पास में, और वहाँ से स्टिमुलेट करते हैं, लीड डालते हैं। दिस इज कॉस्टिंग अराउंड 4 lakhs और समथिंग, एंड इसके बेसिक मेन इंडिकेशन है फेल्ड बैक सर्जरी सिंड्रोम्स विथ रेडिकुलर पेन या न्यूरोपैथिक पेन कंडीशंस में यूज़ करते हैं। ऐसे इंट्राथीकल ड्रग डिलीवरी सिस्टम्स हैं, दे आर अगेन एक्सपेंसिव मॉडलिटी। इनका एडवांटेज क्या होता है कि आपने इंट्राथीकल स्पेस में जाके एक कैथेटर डाल दिया और कैथेटर के थ्रू ड्रग दे रहे हैं, जैसे जो भी हम दे रहे हैं ना, मॉर्फिन देना है तो मॉर्फिन सपोज वी डिसाइड तो वी गिव मॉर्फिन देयर। तो इसमें क्या हुआ कि ब्लड ब्रेन बैरियर नहीं क्रॉस करनी है। जब इंट्राथीकल आप मॉर्फिन दे रहे हो या कोई भी ड्रग दे रहे हो तो डोसेज ऑफ द ड्रग काफ़ी कम हो जाती है, मिनिस्क्यूल हो जाती है, तो डोसेज रिलेटेड साइड इफ़ेक्ट्स कम हो जाते हैं। दैट इज़ ए मेजर एडवांटेज। और कंटिन्यूसली हम दे सकते हैं तो कंटिन्यूस रिस्पॉन्स रहेगा, कंटिन्यूसली पेशेंट में भी पेन फ्री। एंड अनदर एडवांटेज इसका इंट्राथीकल ड्रग डिलीवरी सिस्टम्स का होता है कि दे गिव पोटेंट एनाल्जेसिया विदाउट लॉस ऑफ टच, मोटर फंक्शन और लॉस ऑफ सिंपैथेटिक रिफ्लेक्सेस। तो दे आर यूजफुल एंड दे आर मोर यूजफुल इन केसेस ऑफ कैंसर पेशेंट्स। ऐसे डीप एक मॉडलिटी होती है डीप ब्रेन स्टिमुलेशन। इसमें इलेक्ट्रोड प्लेस करते हैं, ये मतलब हाईली इन्वेजिव टेक्निक है। अगेन आप इलेक्ट्रोड प्लेस करते हो और उससे फिर आप स्टिमुलेट करते हैं। इन्वेजिव है, अभी बहुत ज़्यादा एफिकेसी पे भी कमेंट नहीं करते हैं इसके, बट ये कुछ जगहों पे जैसे यूके में एंड यूरोप में अप्रूव्ड है। तो आई थिंक हमारे गेस्ट को आने शुरू हो गए हैं। आप तो गेस्ट नहीं हो, हमारे तो होस्ट ही हो, सॉरी, बट आई वुड कंक्लूड विद इन 2 minutes। बायो साइको सोशल ट्रीटमेंट क्रॉनिक पेन का जब भी होगा तो यही ट्रीटमेंट है इसका, कि आपको डिफरेंट एस्पेक्ट्स ऑफ बायोमेडिकल, हम लोग जब अभी तक ज़्यादातर मैंने जो बात करी कि बायोमेडिकल बात करी कि ड्रग देनी है, कहाँ से देनी है, कौन सी ड्रग देनी है, इतने ऑप्शन हैं, बट दिस इज़ नॉट द एंड ऑफ इट। साइको सोशल हेल्थ ऑफ द पेशेंट को उतना एड्रेस नहीं किया, जबकि मैंने फिर भी टच किया है, और वो इसलिए नहीं किया बिकॉज ये एक्सपेक्टेशन से कि मैं पेशेंट का पेन ठीक कर दूंगा मेडिसिन से, इंटरवेंशन से, एंड तो मेंटल हेल्थ और एसोसिएटेड क्वालिटी ऑफ हेल्थ उसकी अपने आप अच्छी हो जाएगी, बट इट डजंट हैपन, सो वी हैव टू टेक केयर ऑफ दैट। क्रॉनिक पेन इज जितना फिजियोलॉजिकल है उतना ही साइको सोशल है। अगेन मतलब मे बी मैं 5वीं-6वीं बार बोल रहा हूँ, एंड इट इज़ एसोसिएटेड विथ एंग्जाइटी, डिप्रेशन, स्ट्रेस। हो ही नहीं सकता कोई पेशेंट, जब भी मैं तो आई एम 65+, तो कितनी बार मेरे को पेन हुए हैं ना, कभी बैक का हुआ, कभी हिप का हुआ, कभी नी का हुआ। अब तो नी परमानेंटली पेन करती है। तो ऐसा नहीं, मतलब मैं ये कहना चाह रहा हूँ कि जब भी पेन होता है तो ऐसा लगता है ये कभी नहीं ठीक होगा। मैं अपने एक्सपीरियंस से बता रहा हूँ, एंड इट इज़ वेरी डिस्टर्बिंग, इट इज़ वेरी डिस्टर्बिंग। एंड मतलब आप जिसको अगर नहीं हुआ, जो भी प्रिविलेज है, जिसको नहीं हुआ वो अप्रिशिएट नहीं कर सकता वो, कि हो नहीं सकता उसके साथ डिप्रेशन नहीं हो, उसके साथ एंग्जाइटी नहीं हो, उसके साथ स्ट्रेस नहीं हो। दैट इज़ व्हाट आई वांट टू हाईलाइट। एंड देयरबाय इसके ट्रीटमेंट के लिए मल्टी डिसिप्लिनरी पेन मैनेजमेंट ही करना होगा, विच विल इंक्लूड फिजिशियंस, साइकोलॉजिस्ट, फिजियोथेरेपिस्ट एंड ऑक्यूपेशनल थेरेपिस्ट्स। ये बायो साइको सोशल ट्रीटमेंट का इनका एक जरा सा ब्रीफ देता हूँ आपको। ये एक्चुअली होते कैसे हैं, ये ग्रुप्स में किए जाते हैं ट्रीटमेंट। 10 से 15 लोगों का पेशेंट जो सफ़र करते हैं उनका एक ग्रुप बनाते हैं, उनके सेशंस होते हैं 10 से 12, 8, 10, 12 सेशंस का प्रोग्राम होता है पूरा। हर सेशन 3 से 4 घंटे का होता है, एंड ये सेशंस कितने बार फ्रिक्वेंटली रिपीट करना है, मे बी वीक में 1 बार भी कर सकते हैं, वीक में 2 बार भी कर सकते हैं, डिपेंडिंग ऑन द सिचुएशन, हो सकता है 3 बार भी कर सकते हैं। इनका एक काफ़ी बात करते हैं कॉग्निटिव बिहेवियर थेरेपी की, काफ़ी ज़्यादा इस पर हम लोग ने काफ़ी पढ़ते हैं, काफ़ी लिटरेचर है कि हेल्प करता है ये पेन मैनेजमेंट में। इसका एक जरा सा ब्रीफ देता हूँ कि पेशेंट जो होता है ये पैसिव रिस्पॉन्डर नहीं होता है इसमें, कि आपने बोल दिया ऐसे कर लो, हाथ मोड़ लो, उसने हाथ मोड़ दिया, नहीं, ऐसा नहीं होता। उसको एक्टिवली वो प्रोसेस करता है, उसको कुछ इन्फॉर्मेशंस दी जाती हैं, और उनको पर्सनल रियलिटी में जिस स्टेट में आज है उनको प्रोसेस करता है, एंड पेशेंट से शेयर किया जाता है कि आपकी थॉट प्रोसेस जो उसमें उस समय की आपकी थॉट प्रोसेस है, अगर नेगेटिव थॉट प्रोसेस लेके चलेंगे तो पेन को रिस्पॉन्स नहीं आएगा, थेरेपी का रिस्पॉन्स नहीं आएगा। तो दे प्ले विद द थॉट प्रोसेस ऑफ द पेशेंट एज वेल। सो एक ग्रुप, लार्ज ग्रुप मीटिंग रिपीटेडली, कुछ इन्फॉर्मेशन देते हैं, फिर उसको नेक्स्ट सिटिंग में उसको मॉडिफाई करते हैं पॉजिटिव, तो दे प्ले विद द थॉट्स ऑफ द थिंकिंग प्रोसेस ऑफ द पेशेंट, एंड इट हैज़ बीन सीन इट वर्क्स वेरी वेल। इसके कोर्सेज भी होते हैं, एक कोर्स हुआ था, मैं ज्वाइन करना चाह रहा था, बट समहाउ उस समय अटेंड नहीं कर पाया। अब वर्कशॉप्स भी होती हैं, तो मतलब इट इज़ ए यूज़फुल थिंग। आप लोगों ने किसी ने किया हो तो शेयर कीजिएगा अपने एक्सपीरियंसेस। एक इसी तरह से एक नई थेरेपी आ रही है, अब इमर्ज हो रही है। दिस हैज़ बीन देयर अगेन फॉर लास्ट 10 years, एक्सेप्टेंस एंड कमिटमेंट थेरेपी। ये कहते हैं ये डिफरेंट है उससे, कॉग्निटिव बिहेवियर थेरेपी से बिल्कुल। ये इसमें कहते हैं कि ये जो फीलिंग्स को कहते हैं गई फीलिंग्स, दे डोंट बॉदर अबाउट द फीलिंग्स, आप क्या फील कर रहे हो, क्या थॉट प्रोसेस है, दे लीव इट, कहते हैं इसको छोड़ दो, भूल जाओ, कुछ नहीं है, इसकी हम बात नहीं करते। वो कहते हैं पेशेंट को कहते हैं कुछ नई चीज़ें सिखाते हैं उसी दिन, उसकी कैपेबिलिटी के हिसाब से उसको कुछ स्किल्स देते हैं, उसको कहते हैं उस पर आप एक्ट कीजिए। एंड वही प्रोसेस वही है कि रिपीटेडली मिलेंगे, ग्रुप में करेंगे एक्टिविटी, एंड वो जो नई चीज़ सीखता है करके इन्वॉल्व होता है और उसको एक्साइटमेंट होता है, अगेन नेक्स्ट टाइम टारगेट को रेज करते हैं, एंड इट हैज़ बीन सीन कि इट इज़ एज इफेक्टिव एज कॉग्निटिव बिहेवियर थेरेपी ओवर लास्ट 15 ईयर्स, और एविडेंस भी आ रहा है इसके फेवर में। सो टू कंक्लूड, chronic non-cancer pain is a multi-dimensional problem that must be treated multi-dimensionally, जिसमें क्या फिजिशियन चाहिए, साइकोलॉजिस्ट चाहिए, सोशल अप्रोच चाहिए, फैमिली को भी करना पड़ेगा। सो दैट इज हाउ इट इज, एंड this was the article from where I have taken majority of my presentation. Thank you so much.
Thank you so much, sir. It was a delight and privilege to hear your lecture. We will be shortly beginning our inauguration ceremony of the CME as soon as Vice Chancellor sir arrive. A very good morning to all of you present here. I, Dr. Shashank Kumar, on the behalf of Department of Anesthesia, extend a hearty welcome to all the esteemed faculty members, pain physicians, invited guest speakers, honorable guests, and delegates to this CME with hands-on cadaveric workshop on chronic pain management. Chronic pain is of great concern to health professionals, patients, society, and it negatively impacts the quality of life. Considering this burden, the pain unit of Department of Anesthesia KGMU decided to conduct this two-day academic feast with the aim to change physicians' perspective of diagnosing and managing chronic pain. Although we have been conducting lots of pain CME and workshop in the past, but it is the first of its own kind workshop that is being organized by the Pain and Palliative Care Unit of Department of Anesthesia KGMU. I would like to have the privilege of inviting our respected guests to take their seats on the dais, Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri sir, Pro Vice Chancellor Dr. Vineet Sharma sir, Guest of Honor Dr. Anil Agarwal sir, Head of the Department, our patron Dr. GP Singh sir, Special Guest Secretary ISPC Dr. Anil Agarwal sir, Secretary ISSP Dr. Major Pankaj Surange sir, and as organizing chairperson Dr. Sarita Singh ma'am. I would also like to welcome CMS sir Dr. S.N. Sankwar sir. Flowers are a beautiful way of expressing gratitude. So I would like to request our organizing chairperson, Dr. Sarita Singh ma'am, to kindly present floral welcome Ekal Pushp to our guests. Chief guest, Honorable Vice Chancellor sir. Pro Vice Chancellor Dr. Vineet Sharma sir. Dr. Anil Agarwal sir. Our patron HOD sir. CMS Shankwar sir. Dr. Anurag Agarwal sir. Dr. Major Pankaj Surange sir. Any educational event is not complete without remembering Ma Saraswati. We invoke Ma Sharda's blessing to dispel ignorance and ignite the light of knowledge in our minds. As a token of reverence to Ma Veena Vadini, we will have the Prejudice Ceremony. Now I would like to call all the dignitaries to please come up for lamp lighting ceremony.
स्वतंत्र रव अमृत मंत्र रव प्रिय स्वतंत्र रव अमृत मंत्र रव भारत में भर दे वीणा वादिनी वर दे वीणा वादिनी वर दे।
Thank you so much, respected guests. Please have your seat. It gives me immense pleasure to invite on the podium our patron, persevering, determined and dedicated head of the department, Professor GP Singh sir, to deliver the welcome address.
Thank you, Shashank. और जय श्री राम। इसलिए कि आज का दिन बहुत ही शुभ दिन है। आज बहुत सारे पर्व मनाए जा रहे हैं। आज हिंदू वर्ष का नव वर्ष है, इसलिए नव वर्ष की सभी के लिए मंगल कामना। नवरात्रि का पहला दिन है, इसलिए माँ से प्रार्थना है कि हम सब पर माँ अपनी कृपा दृष्टि बनाए रखे, हम सबका कल्याण करे। Dignitaries on the dais, General Bipin Puri sir, our Vice Chancellor, Pro Vice Chancellor Dr. Vineet Sharma साहब,
Dr. Anil Agarwal, ex-HOD, Anesthesia, Sanjay Gandhi PGI, our friend Anurag, Dr. Pankaj, our friend CMS, Dr. Sankhwar, Dr. Chakravarti, Devasi Chakravarti from Calcutta, na? Devjyoti, Dr. Ajika from Muzaffarnagar, faculty in KGMU and Department of Anesthesia particularly, residents, delegates, ladies and gentlemen. Very warm welcome to all of you. I am very grateful to my Vice Chancellor, who is always very gracious and very keen to attend such workshops and conferences. He has always inspired us and always supported the Department of Anesthesia. Thank you, sir, for sparing time and giving blessings us. Dr. V. Sharma Sahab, our friend, he is very kind to the department, no doubt, and always a smiling person. Dr. Anil Agarwal Sahab, welcome you, sir. Dr. Pankaj ji, welcome you. This workshop is meant for non-cancerous patients, rather chronic patient. Chronic pain is very debilitating. As Anil Agarwal Sahab was telling it has got socio-physical component also. So I hope delegates will be benefited by this workshop and will help the patients in alleviating their sufferings. Because chronic pain, if persists, it decreases the productive time of the person. So we have to be very careful. In this CME, there are around 80 delegates, out of which 35 are registered for workshop. अंत में मैं कहूँगा नलाख्यो वत्सरम नूनम आरोग्यवर्धक भारतस्य प्रतिष्ठार्थम भू मंगलदायक। हमारे जैसे हमारा भारतवर्ष का या हमारे संस्कृति है, सबको वसुधैव कुटुंबकम की हमारी विचारधारा है। सबको स्वस्थ रहे, सब लोग स्वस्थ रहें और सब लोग दीर्घायु हों, ये हमारी कामना है। और CME के लिए बहुत बहुत शुभकामना देते हुए मैं अपनी वाणी को विराम देता हूँ। बहुत बहुत धन्यवाद। लेकिन मैं इसमें ज़रूर कहना चाहूँगा कि जैसा मोदी जी ने योग के बारे में कहा है और अनिल अग्रवाल साहब अभी कह रहे थे फिजिकल सोमैटिक डिसऑर्डर हो सकता है पेन में, तो योग का भी इसमें पेन के एलिवेशन में योग का भी वर्णन होना चाहिए, इसको इंक्लूड करना चाहिए। थैंक यू।
Thank you so much, sir, for your promising and heartening words. I feel extremely elated to call our zealous, devoted, and hard-working organizing chairperson, Professor Sarita Singh ma'am, to address the audience.
Thank you, Dr. Shashank. Good morning to all of you. On behalf of Department of Anesthesiology, Pain Medicine Unit, I extend my very warm welcome to the Honorable Vice Chancellor, Lieutenant General Dr. Bippu Puri, Pro Vice Chancellor Dr. Vinit Sharma, Guest of Honor Dr. Anil Agarwal, Head of the Department of Anesthesiology Dr. G.P. Singh Sir, Chief Medical Superintendent of the University Dr. S.N. Sankhwar Sir, Secretary of Indian Society of Pain Clinicians Dr. Anurag Agarwal, Secretary of Indian Society for the Study of Pain Dr. Major Pankaj Surange, and all invited esteemed guest faculty, faculty of my department, delegates, colleagues, and dear students. I welcome you all once again on this occasion of 2 days CME and Cadaveric workshop on chronic pain management like back pain, multiple joint pain, various types of neuropathic pain of trigeminal neuralgia, CRPS, and radicular pain. The purpose of organizing this CME is to sensitize, educate, and train the new buddings of this specialty. Pain medicine is an emerging branch, and now it has started taking the shape of a separate department or divisions in various institutes of India as a super specialty. Recently, new department of pain medicine has been created in GSVM, Kanpur Medical College, Uttar Pradesh. and AIMS Rishikesh has already started DM course in pain medicine. Many institutes of India are trying to start DM and DNB courses in pain medicine. There is also a need of creating a separate department or division for this specialty in our institute also, because our institute is serving a very large population of Uttar Pradesh and nearby states. There are many cancer and non-cancer patients who need the services of pain medicine to relieve their sufferings from their intractable chronic pain. In this context, Department of Anesthesiology Pain Medicine Unit has been organizing various CME and workshops on regular basis since past 5 years. Till now, we have trained more than 100 doctors in various pain procedures by using ultrasound machine, fluoroscopy machine, and radio frequency listening machines. Pain Medicine Unit is also going to start a new step in the pain management with the blessings of our Honorable Vice Chancellor and Head of the Department, that is minimally invasive endoscopic pain procedure for chronic back pain under local anesthesia. This will be a boon for those patients who have severe comorbidities and not fit for surgery. These minimally invasive procedures will relieve the pain of those group of patients. I hope this 2-day CME and Cadaveric workshop will provide a good platform for learning the subject by the galaxy of pain specialists who have come across India. Thank you all for coming and sparing your time to join us from your busy schedule. Thank you very much.
Thank you so much, ma'am, for your enlightening and encouraging words. It gives me profound delight to invite energetic and enthusiastic Secretary of ISPC, Dr. Anil Agarwal sir, to say a few words. Sir is a proficient pain physician and currently practicing in RML and has been consistently working in this field for pain relief of the patient.
Good afternoon, everybody. I'm really delighted to be here in this CME and at one of the most prestigious and known medical institute of India, which is known globally for its new initiative. I thank Dr. Sarita Singh and the organizing team, respected VC sir, Pro VC sir, head of the department sir, CMS sir, and my senior teacher, Professor Anil Agarwalser, my dear friend Dr. Surange, who is also the Secretary of Indian Society for Study of Pain, that is ISSP, our mother body. Actually, that is the original body which was formed in way back in 1986. And ours, Indian Society of Pain Clinicians, is the new and niche body who is being comprised of the pain physicians who have been formally trained at least for 1 year in the pain medicine. So the first PDCC course was started, sir, at BHU Varanasi, and which was followed by the gentleman just besides you, Professor Anil Agarwal sir, just 2 years after that BHU course at SGPGI. And now, because of the hard work of these stalwarts, Dr. Rastogi, Dr. Anil Agarwal sir, and many more, now we have reached to a place when we have actually the first and only 3 years course in pain medicine with the name of DM Pain Medicine at Rishikesh AIMS. Currently, many institutes are trying to get an NMC nod for the start of DM Pain Medicine, because AIMS doesn't come under the purview of NMC. So, but many institutes are sincerely trying. As Dr. Sarita Singh has just informed, that first Department of Pain Medicine, which has been notified by the government of Uttar Pradesh at PMSSY Medical Institute at GSVM Medical College Kanpur, for which the posts have been created. Also, there is a news that as a member of National Board of NBA of Pain Medicine Board, I am delighted to inform the gathering, because most of us are here from the anesthesia background, that FNB Pain Medicine has also been notified from the NBE. From this June, I hope that there will be multiple centers of excellence which will be providing quality education in the pain medicine. Why it is required, sir? Because age of living is increasing by the efforts of everybody, including the government in our country as well, and so are the degenerative conditions. And these subset of people, our senior population in the country, in the world, they require our services, which are minimally invasive pain and spine interventions. So this is something like the cardiology. When the patient is not fit for the CABG, he goes for angioplasty, and he is spared of the morbidity and the other associated things of the open surgeries. Same way we pain and spine physicians try to treat the chronic ailments of the spine and other all over the body pains, which are very dreadful many times, and by the minimally invasive interventions. So these things are our niche. As they are of cardiology by their percutaneous cardiac interventions. So I hope and I wish, as the Secretary of Indian Society of Pain Clinicians, we always push for the quality and standardized education in all the field, especially our field, that is pain medicine. And I hope and I request to the authorities, especially VC sir, to consider, as the KGMU has been always a lighting guidance for all the new initiatives in medical education field. So I hope that again KGMU will be one of the leading and first institute in the country to start department as well as the DM course. And by which, sir, this one last line which I would like to say, that we are at par to the another big country in the pain medicine, that's America. We are perhaps better in many senses from the Europeans. We are far ahead from all the Middle East and the Africa. So there is a huge potential for the medical tourism, both in the senses of patient as well as the doctors. Dr. Pankaj Major Surange, sitting here, he is having his own center in Delhi, and he is regularly having foreign candidates who are coming in India for the learning purposes. So if we can find a way to attract them, we can have a huge potential and getting foreign candidates who will be very much willing to come into the India to learn these things. With these, I rest my voice. Thank you again for this opportunity. My lecture is later on, so we will meet again. Thank you.
Thank you so much, sir, for your insightful words. Keep on motivating us like with your work. This stage is also graced by the presence of a name who needs no introduction in pain medicine, our special guest, Secretary ISSP, Dr. Major Pankaj N. Surange, sir. He has been conferred with many awards to his glory, be it National Pain Physician Award 2016, Pain Awareness Ambassador Award 2016, and also honored by the World Institute of Pain. I would like Pankaj Surange, sir, to kindly address the audience with your enchanting voice.
Respected dignitaries on the dais, the gathering here, young pain physicians, and also the budding pain physicians. So as we all know that pain medicine in last maybe a decade, we have seen a tremendous growth in the department, in the field of the pain medicine as a specialty. So why there's a need of a specialty? Because the burden of the disease is increasing. The chronic pain patients, the number of pain patients, chronic pain patients, that has been regularly increasing since last many decades. And that is why we have a need of this specialty of pain medicine. As Dr. Sarita and Dr. Anurag, what they mentioned, we have this DM in pain medicine now. We have FNB in pain medicine now. Okay. Now there's a need of the departments. We have hospitals, pain specialty hospitals all over India now. Why this is a requirement? WHO already mentioned that it is the human basic right. Pain relief is a human right. But are we doing enough to control, to give this human right to the public? So that is the need. WHO has also recently they have come out with one paper where they have mentioned that 80% of the patients who are suffering from chronic pain, they are not getting adequate pain relief. So these are the two reports by the WHO. And with this, I would request all the budding pain physicians who are sitting here and dignitaries on the dais, I would request them to do something to give the pain relief to the public who are suffering from chronic pain. We can do a lot as a society, as clinicians, as academicians. We can do a lot to give the pain relief to these patients who are suffering from chronic pain. Thank you very much. Thank you very much to all. Thank you.
Thank you so much, sir, for your pleasing words. Now I would like to call our disciplined and devoted Chief Medical Superintendent of Gandhi Memorial Hospital, Professor S.N. Shankwar, sir, to kindly enlighten us with his graceful words.
Thank you, Dr. Sasank. Good morning, all of you. Chief guest of today's function, our most honorable Vice Chancellor, Lieutenant General Bipin Puri, sir, Pro Vice Chancellor, sir, Head of Department of Anesthesia, Dr. Anil Agarwal, sir, Dr. Manoj Agarwal, sir, Dr. Surange, Organizing Secretary, Dr. Sarita ji and Dr. Ajay, faculty members of the Anesthesia Department and the delegates coming from other institute. My warm welcome to all of you. And as you know, the pain is a very problematic situation with anybody, and the person who is suffering of any type of the pain, chronic pain, cannot give his 100%. So this is a very important subject on which this CME is being held today. So I give my best wishes for this, and one request to the delegates: whichever knowledge you gain, you should spread that knowledge, you should utilize that knowledge for the service of mankind. Thank you very much. Jai Hind.
Thank you so much, sir, for your encouraging words. Now I request the privilege of a guest of honor, the stalwart of pain medicine academician par excellence, ex-president of ISPC and ex-HOD, Department of Anesthesia, SGPGI, Dr. Anil Agarwal, sir, to grace the podium and say a few words.
Good afternoon, dignitaries on the dais and other fellow colleagues. Basically, I was thinking I would talk on, or rather emphasize on the need of start of MD in pain, and MD and maybe DNB in institutes. Like I was in PGI, so that we were striving very hard for a start of DNB there, and an institute like yours, MD should be, I would have thought that MD would have started from here. KGMC must have been the first institute to start MD classes, MD in pain medicine. But still, nothing is lost. We must strive very hard to start MD in pain medicine at the earliest. Another thing, I just wanted to share कि पेन का अगर किसी को डाउट है स्कोप के बारे में कि कितना स्कोप है पेन मेडिसिन की ट्रेनिंग का, टीचिंग का, तो नटसेल में आपसे शेयर करना चाहूँगा. I retired from SGPGI 3 months back, joined Apollo Medics on 1st Jan 22 में. And in 3 months, we have started a pain clinic there, regular, daily, 6 days a week pain clinic. We are running actively. I've got a RF machine. Being in a private, it is an advantage कि 2.5 महीने में आ गई RF machine आ गई. It is with us right now. We did our first trigeminal Gaussian ganglion by our own machine. So, and there was a case. Abhi parso I was sitting in my OPD. A case came that was a post cesarean 10 दिन पुराना जिसको हम लोगों ने अपोलो में इसका किया था cesarean. She comes and says कि उसको she developed myofascial pain. तो myofascial pain का कि सर में यहाँ से पीठ से पेन उठता है, सर में जाके टनने से बोलता है, and everything ना, that those kind of history was there. A colleague of mine was sitting by मेरे साइड में एग्जामिन कर रही थी. वो she thought कि इसको न्यूरोलॉजी में भेजते हैं सर, कुछ लग रहा है. हमने कहा उसको हेडेक हो रहा है. हेडेक हुआ, वोमिटिंग हुई, नहीं हुई. नेक स्टिफनेस है, नहीं है. तो न्यूरोलॉजी में क्यों भेजोगे? मैंने कहा स्कूल प्रोन करके लिटा लो. हाँ, तो लिटा के देखा तो देयर वाज ए मायोफेशियल पेन. हमने कहा मायोफेशियल पेन यूटिलाइज कर देंगे, ठीक हो जाओगे, कोई इशू नहीं, डन. तो मैं इसमें दूसरी एक स्टोरी, इसमें हिडन स्टोरी थी. जब पेशेंट से बात कर रहे हैं तो पेशेंट कह रहा है कह नहीं रहा, शी वॉज कंप्लेनिंग कि जब सर्जरी होगी बिल्कुल पेनफुल, एब्सोल्युटली पेन फ्री सर्जरी हुई मेरी, लेकिन सर्जरी के बाद में उन्होंने यहाँ से कुछ ऐसे किया, 2 इंजेक्शन साइड से दिए. वी हैड गिवन QL, हमारा प्रोटोकॉल है, हम QL देते हैं उनको, क्वाड्रेटस लंबोरम ब्लॉक देते हैं. तो कहती 2 दिन तक मेरे को स्टिच का भी पेन नहीं हुआ. तो शी वॉज कंप्लेनिंग कि स्टिच का भी पेन नहीं हुआ. मैंने इससे लेसन लिया उसी समय. आज कल जाके फैकल्टी मीटिंग कॉल करूँगा कि नहीं, आपने बहुत अच्छा काम कर रहे हो, बट स्टिल द पेशेंट इज सेइंग कि कंप्लेन कर रही रादर देन अप्रिशिएटिंग, कि वो कहती कि अपोलो में ऐसा काम हुआ कि हम और मतलब और लोग को कराना चाहिए, सबको ऑफर करना चाहिए. रादर शी इज कंप्लेनिंग कि पेन भी नहीं हुआ. तो मतलब ये है, हम लोग इतना अच्छा काम, सब लोग काम करते हैं पेन में, बट अभी वो रिकग्निशन के लिए वी हैव टू. प्रॉब्लम क्या थी इसका मतलब, हम उनको पेशेंट को बताया नहीं हमने ना कि तुम्हें पेन फ्री एनेस्थीसिया हम दे सकते हैं. आर यू विलिंग फॉर इट? If you are willing, we'll do this, and you will be pain free for at least 2 days. So we have to do a lot. Thank you.
Thank you so much, sir, for sparing your valuable time and blessing us with your intellectual words. Now I call upon our proficient and dynamic Pro Vice Chancellor, Professor Vineet Sharma, sir, to please address the audience.
Thank you, dear. Respected Honorable Vice Chancellor, Lieutenant Anil Puri, dignitaries on the dais and off the dais, especially mentioning Head of the Department, Dr. G.P. Singh and Dr. Sarita Singh, who have been able to organize this conference. Nothing can be more grateful than to relieve a person with pain, and who else can understand better than an orthopedic surgeon. Chronic pain is one of the most disabling problems that we face day to day. And I tell you, look at the face of a patient who has been relieved of that pain. And of course, as we have an aging population, this problem is increasing day by day, whether it is back pain, neck pain, whether it is joint pain or any other pain. I'm sure the Cadaveric workshop that has been organized will be a boon to the budding pain physicians, and I'm sure you'll learn a lot and bring that into practice, helping the patients at large. Thank you very much.
Thank you, sir, for your gladdening and heartwarming words. I request the honor of a committed, proactive and inspiring Honorable Vice Chancellor, Lieutenant General Dr. Bipin Puri, sir, to please grace us with your invigorating words. Sir has been a constant support to us at each level and leading us at all fronts.
So, Professor G.P. Singh, Head of Department of Anesthesia, Critical Care, Professor Sarita, who is the faculty in charge of the pain clinic at KGMU, and a very distinguished galaxy of pain specialists that we have today are here on the dais as well as in the audience. Delegates, the residents who have come in to attend this conference, this CME, plus this workshop, ladies and gentlemen. On behalf of this university, I accord a very warm welcome to all of you. I'm very pleased to be here this morning, and as I join up with the Department of Anesthesia for a host of academic activities, I have to compliment Professor G.P. Singh for doing so much for his department, really exceptional. Just a couple of weeks ago, we've been doing PG quizzes, we've been doing difficult airways, we've been doing one lung ventilation, and etc., and now this pain management. Friends, boys and girls, residents, doctors, ladies and gentlemen, pain management today is becoming, as has been talked about by the stalwarts, is a very specialized quality of care. We are looking at quality of care issues in today's times. As the age is advancing, and we have better medical procedures available for age advancement, and as we are all aware, the dependency on medical professionals to look after and look at quality of life issues continues to be the single most important thing. And towards that extent, I think the Department of Anesthesia, the concept of this anesthesia physician concept that you all were talking about some time ago, and I think that role is expanding, that you are not only intensivists, you're not only looking after critical care, you're not looking after the operation theater, but you're also looking after the patients, whether it's in the pre-op setting, optimizing their treatment, optimizing their medical and surgical treatment, and before you take them under the knife, and also rehabilitating them and looking after pain management, which is not only acute pain management, but also on a long-term management, that what we are talking of today. So with that in the backdrop, I think there is a growing demand. Unrelieved pain is a problem. It is a problem faced by society at large, and I'm actually, for me, it's awareness that we had a national body on pain relief. So and we have national secretaries here this morning. So I think it's a cause of huge sense of pride for us as healthcare professionals, that we can reach out to the aggrieved patients in pain and do whatever we possibly can. And I'm very happy to see that the Department of Anesthesia here at KGMU is leading from the front. And I know Professor Sarita is a very, very energetic, very aggressive in her pain management technologies, and they're doing it all, whether it's pharmacological treatment, whether it's patient-controlled analgesia, whether it's field blocks or regional blocks. So whatever, they do the entire spectrum. I'm aware of it, and I'm very, very proud of the department, the pain management team here at KGMU. I must also say that the various types of pain management thing in recent past, what has been brought to my notice is not only neuropathic pains, cluster headaches, joint pains. So they're doing it all. So I think this workshop which Professor Sarita and Professor GP are talking about, which is going to help you to actually do a hands-on thing, I think it's going to be very beneficial, because you do these various types of blocks and radio frequency ablations, genicular nerve, stellate ganglion, and lumbar sympathetic blocks, facet joint denervations, biculoplasty, that is that heat generated between two discs. Now, so I think all of this is going to be very, very interesting, very fascinating, newer things, newer techniques of pain relief, and I sincerely believe that should really be the way to go. We have recently, as Professor Sarita said, asked for an endoscopic decompression set for pain clinic, which will, I'm sure, will further empower the pain faculty team for doing even better for foramen decompression for back pain. So, friends, ladies and gentlemen, once again, I think it is a time that we look at some sort of a postgraduate training, a formalized training. We would address this issue, and as has been said by the stalwarts, we will definitely take it up in the academic council meeting and try and take this forward as far as a postgraduate training in pain management is concerned. And with these few words, once again, I congratulate the Department of Anesthesia, Professor G.P. Singh, Professor Sarita, and the entire galaxy of speakers, the faculty who has come in this morning to help us to deliver knowledge to the generation next. Thank you, ladies and gentlemen.
Thank you so much, sir, for boosting our morale and adorning us with your pearls of wisdom. As a token of gratitude, we would like to present planter and a memento to Honorable Vice Chancellor, sir. I request our HOD, sir, to please kindly present them to Vice Chancellor, sir. Now I request HOD, sir, to kindly felicitate Pro Vice Chancellor, Professor Vineet Sharma, sir. I request Honorable Vice Chancellor, sir, to kindly felicitate our guest of honor, Dr. Anil Agarwal, sir. I request our organizing chairperson, Dr. Sarita Singh ma'am, to kindly present planter and memento to our patron HOD, Dr. GP Singh, sir. Now I request Dr. Ajay Chaudhary, sir, to present the memento to CMS, sir. Now I request our organizing secretary, Dr. Manish Singh, sir, to felicitate Dr. Anurag Agarwal, sir. I request Dr. Manish Singh, sir, to kindly felicitate Dr. Major Pankaj and Surange, sir. Now I request our HOD, sir, Dr. Sarita Singh ma'am and Manish Singh, sir, to kindly felicitate all the guest speakers here. To begin with Dr. Devjyoti Datta, sir. He is an alumnus of KGMU Department of Anesthesia. He is a known name in pain medicine in Kolkata. He is working in Daradia Pain Clinic under Dr. Gautam Das, sir. Dr. Amitesh Pathak, sir. Dr. Amitesh Pathak, sir, from Integral Medical College. Dr. Shivani Rastogi, ma'am, from RML Institute of Medical Sciences, Lucknow. I would like to call upon our diligent and high-spirited organizing secretary, Dr. Manish Singh, sir, to deliver the vote of thanks.
Thank you, Shashank. Honorable Vice Chancellor, sir, Lieutenant General Bhupuri, sir, respected Professor Vineet Sharma, sir, our Head of Department, Professor GP Singh, sir, our most valuable invited guests, ladies and gentlemen. It's my privilege to offer vote of thanks on this occasion on the behalf of Department of Anesthesia. I would like to thank our Honorable Vice Chancellor, sir, for who honored us this function with his inspirational thoughts and blessings. I must mention deep sense of gratitude to our guest of honor, my mentor and guide, Professor Dr. Anil Agarwal, sir. I would like to thank you for a very informative talk on overview of pain management. I would like to express my gratitude to Professor Vineet Sharma, sir, for his blessings. I would like to thank our Head of Department, Professor GP Singh, sir, for his constant guidance and support in organizing these kinds of workshops. Special mention to our CMS, Professor S.N. Sankhwar, sir, who had been very instrumental in conducting the CME and this workshop. I would like to thank Dr. Major Pankaj Surange, Dr. Anurag Agarwal, sir, for gracing us with their presence. I would like to thank organizing chairperson, Professor Sarita Singh ma'am, for guiding us on planning and execution of this program. I would like to thank Professor Ajay Chaudhary sir for conducting this CME and workshop. I would like to thank all delegates and speakers who are coming, who had come for this workshop. I have been very fortunate to back by team. I thank my team. I also thank IIT team, our staff for their cooperation in organizing this workshop. I would like to thank media. And ladies and gentlemen, once again, I would like to say that we are most grateful to all speakers on this forum. We thank you all for being with us. It's a great pleasure. Thank you.
A very heartfelt thanks to you, sir, for constantly working with us with such vigor and making this CME workshop a success. To conclude this inauguration ceremony, let's stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much, everyone. I would request the guests to please move for some snacks and tea. There is a break for 5 minutes and then we will continue with the next CME session. Good afternoon, everyone. Now we will be beginning with the second session of the CME. The next session on transforaminal interventions, how to perform and how they work, shall be taken up by Dr. Deven Singh, sir. Sir is a consultant and head of interventional pain management, Sahara Hospital, Lucknow. His area of interest are transforaminal endoscopic procedures, percutaneous disc compression procedure, annuloplasty, radiofrequency ablative procedure. His total number of publication in pain is 2, and he has presented 2 scientific papers on treatment of trigeminal neuralgia by radiofrequency ablation of Gasserian ganglion and continuous LSB in managing refractory phantom pain, and in ISSP Con 2012. He has presented 2 scientific papers in Indo-UK Pain Conference on Low Back Pain and USG Guided Nerve Block, ICPM, on percutaneous nucleoplasty and radiofrequency ablation of medial branch block. I request sir to please kindly present his talk.
कॉलर माइक की जरूरत नहीं है ये बंद कर ले यार बहुत आवाज आ रही है Good morning everybody. It's a great pleasure again after the long COVID era to start CMEs and workshop offline, and I congratulate and thanks all the organizers of KGMU, Lohia Institute, SGPGI, and all our ISSP colleagues and other students and practitioners whoever are attending the CME. I think I have missed initial few lectures, but this is how to begin now, because as a pain practitioner, interventionist and a spine interventionist, transforaminal procedures are like I would say like a basic bread and butter, and they constitute more than 70% of your clinical practice in regarding to interventions. Because I am seeing a lot of new faces which I have never seen earlier, please raise your hand who are all practicing people, who are all practicing. And the students, so most of them are students. So you have to focus on the approaches of transforaminal basic procedures. Transforaminal, there are other endoscopic procedures also, but here we are focusing only on transforaminal neuroplastic or transforaminal epidural procedures. So the spinal pain, in the practice of chronic pain management, spinal pain is the most common type of chronic pain suffered, which has been reported a prevalence of lifetime about 80%, maximum up to 80%. There are many structures which are responsible for as a pain generator. It can be the disc, it can be the facet joint, it can be ligaments, fascia, muscles, and nerve root, dura are the tissues which are capable of transmitting pain in the low back. In addition to the mechanical component, the inflammation of the compressed nerve root is an important factor in the pathophysiology of the radicular and the discogenic pain. There are 3 epidural approaches, among which the transforaminal is one of the approach. In your anesthesia practice, you have learned and mastered about the epidural, which is an interlaminar epidural for anesthesia or the pain relief. So that is one procedure, that is one approach. The second approach is the caudal approach, and the third approach is your transforaminal. All the 3 approaches transmit the pharmacological agents in the epidural space, but there are all the three techniques place the pharmacological agents in the different space. Some like your epidural, interlaminar and the caudal approach, they place the pharmacological agent in the dorsal epidural space or maximum up to the lateral epidural space. But the transforaminal, it goes up to the lateral and the anterior most part of the epidural space. So having the advantage of being the target specific and the using the smallest volume and fulfilling the aim of reaching the primary site of pathology, that is a ventrolateral epidural space, is the most advantageous for this transforaminal approach. Indications, the diagnosis and especially the treatment of the significant radicular pain with or without radiculopathy. You must also understand the difference between the radicular pain and the radiculopathy. In patients who have failed trial of conservative therapy, that is, conservative therapy includes medical management, physical therapies, rest. As a therapeutic procedures, they are much better supported in the lumbar spine than in the cervical or the thoracic spine. This is what the evidence says. Contraindications as per all interventions: systemic or the local infection at the injection site, allergies to the medications, pregnancy or the significant coagulopathy. They are common contraindications. See, now the question arises in your minds also and in the specialties of other branches also, that how it works. Some people say it won't work. It works like any other steroid put anywhere in the body. So you can always tell transforaminal steroid, you should also know very well what is the pathophysiology of the pain in the back and the radicular component and how they work. The causes of radicular pain in the degenerative lumbar spines are, in addition to there is a mechanical compression which may be due to the secondary canal stenosis, which may be due to the disc bulge or a herniated disc. In addition to the mechanical compression, the inflammatory changes which are around the nerve root, the venous congestion and hematogenous disability are the main factors which are responsible for the generation of pain. Either it is a low back pain or it is a radicular pain. See, remember, the mechanical compression cannot, if it is a progressive mechanical compression, it would ultimately lead to the deficit. Or if it is an acute leading to the both sensory and the motor deficit, then the treatment of choice is a decompression. Either it is a surgical or it is a minimally invasive like a percutaneous endoscopic decompression. But when the pain is chronic, it has lasted more than 6 weeks or few months and there is a disability in the function, then the component is not only the mechanical but also the inflammatory component, because it is not progressing, it is not leading to the disability of the patient, but it is constantly giving him a pain which is compromising the functions. So in that case, the functional disability is maximum not due to the mechanical compression, but due to the inflammatory pathology which is growing in the foraminal space. So transforaminal steroid maximizes the drug concentration towards the anterior extradural space of the nerve root, which is the core component, where lies the dorsal root ganglia, where lies the exiting root, where lies the traversing root of the spine. So there are two approaches basically for the transforaminal. Placing the needle and placing the drug in a transforaminal space, there are two basic approaches. One is the Camben's triangle approach and other is a subpedicular approach. See, if you see most of I think the students who are there, they must have been aware and they must have gone through this word Camben's triangle. This is a triangle, it is a safe zone in the transforaminal space where the one part of the triangle is by the exiting root, the other is the base of the caudal vertebra and the other is the traversing root. So this is the Camben's approach. Camben's approach, it is used, the Camben's approach, it is made by the exiting root
what I told, base of the superior border of the caudal vertebra, and the height is the dura or the traversing root. This approach is little bit different, but people maximum the practice is to go through the subpedicular approach, because initially when you learn the transforaminal techniques, you focus on the pedicle. You focus on the pedicle, you make the pedicle, you make the parallel the end plates, and then you proceed. So subpedicular is an easy to locate and standardize and start with, but it is the most commonly approach. The target is the inflammatory site between the back of the herniated disc and the anterior nerve root dural sleeve. But the risk of injuring, in this case, the risk of injuring dura is less, but the risk of entering into the vascular compartment is more, because in the subpedicular area lies the branch of the radicular artery, which is the Adam-Kivick's artery. The literature and the research, everything has shown that the most of the time this artery is between the T9 and L1 vertebra. But 20% of the time the artery lies between the L1 and L5 also, which is the most common sites used for the transforaminal approaches. But to save that approach, to save the accidental installation of drug into the arterial space, the Camben's approach is a safer one, because it can prevent the vascular and the nervous system and prevent the chronic nerve root edema or the epidural bleeding or the epidural scarring. So there is a difference. This is a diagrammatic representation. If this is a pedicle and this is an exiting root, Camben's approach is this, where you have located this triangle. This is the triangle, Camben's triangle, and this is the approach. If you are approaching this triangle, basically it is the intradiscal area. In anterior approach, if you see, it is the disc area which you approach, and if you approach at the base of the triangle, it is the most safest part, where there is no vascular component in the 20% area. If there is a base, if you lower 20% of the base of the triangle is the area which is the safest in terms of the vascular vessels. So if you approach this way, then also you can deliver the pharmacodynamic agent in the transforaminal space. And this is the subpedicular approach, where exactly 6 o'clock to the pedicle you enter. So now what, when you enter inside, so this is the Camben's approach. In Camben's approach, once you parallel the end plates and you make the oblique view, this is the view which is seen, and you approach lateral to the pars intermedia, or the lateral to the, you can see the facet joint. It is lateral to the facet joint where you go, and the needle is curved at the tip so that you can better steer it wherever you want, laterally or medially. And this is the lateral view. In lateral view, when you see, the tip of the needle is in the lowermost part of the foramen, lowermost and outer 1/3 part. This is exactly where the needle position tip in the Camben's approach. And this is when you give the contrast agent. Here the tip of the needle is posteriorly an inferior portion of the foramen. So the chances of nerve prick is the least. And this is your subpedicular approach. In subpedicular approach, you proceed 6 o'clock lateral to the pars, 6 o'clock to the pedicle. And when you see the lateral anterior, this is the anterior placement in the starting, and this is the end point. This is the lateral and this is the AP view of the end point. In the lateral view, you see your needle is in the superior part of the foramen, superior and most anteriorly as much as you can go till the patient feels the paresthesia. This part is little sensitive, because you have to approach very gradually, and explain the patient that as soon as he interacts with paresthesia, you have to stop, because then you can create a nerve root injury. So there you can stop, and then when you give the dye, because there are ligaments, there are connective tissue also in the foramen. So when there is a traction on the ligaments of the foramen, which are connected to because nerve root is hanging in between the ligaments. So when you put the needle in this space, immediately there is a little bit of traction on some of the ligament, and the patient will feel paresthesia. Your needle has not touched the dural sleeve, but still the patient can feel the paresthesia. That is the place where you have to stop, instill the contrast agent, and you can see the contrast agent here, which is absolutely in the anterior epidural space. You will see the contrast agent anterior to the foramen, and in the AP view you can see the traversing root. Very clearly you can see the traversing root. So in this approach, subpedicular approach, you instill the drug exactly posterolateral to the disc, between the disc and the nerve root, but there are chances of needle prick. So, and there is also the chance of interacting with the vascular component. So once you start the transforaminal technique, it's better to approach the Camben's approach. When you have done enough number of cases in the Camben's approach, then you proceed to the subpedicular approach. But there are studies which tell that long-term effects are same, whether you go with the subpedicular approach or with the Camben's approach. There is no significant difference between the two techniques in the initial pain and the pain after 2 weeks, and the pain changes after 4 weeks. Similarly, there is no statistical difference between the two groups in the patient satisfaction index and the therapeutic success assessed after a month. Complications, there are 20% cases where you interact with the paresthesia, or there is a nerve prick during the injection. But when in the Campbell's triangles approach, if you are approaching lower 20% of the base of the triangle, there is hardly any chance of interacting with the nerve root. Intravascular injection, though they are common in the both approaches, but they are more in the subpedicular approach. But there are studies which have shown that even if you have a paresthesia, or you might suspect a needle prick to the nerve roots, then also usually because you are careful and you know that when you are approaching in that way, you might interact with the nerve root. So most of the time there are no long-term complications even if you elicit the nerve prick, but not in a blind way. When you anticipate the things, you recognize the things early, and then you can save more damage. So the procedure can elevate the pain in 1/3 of the patients, and half of the patients showed improvement in the physical functions, especially in the degenerative spinal stenosis. Intravascular complications can be avoided if the needle placement is in the lower 20% of the area of the Camben's triangle. So this is the basic, and I wanted that whatever, if anyone wants to have any question, I'll answer it. Because this is a technique, when you start doing the procedures, when you start doing the cases, then only you can interact what type of problem you exactly feel. There are many things which are not written in the slide, but you interact when you perform the transfemoral procedure, right from the vasovagal to the bradycardias and everything. There are many things when you do the procedures, then you interact. So any questions from any of the students and the... So these are the two techniques, the Camben's and the subpedicular approach. And next time when you decide the transforaminal, don't go for any of the technique, whatever you find. You decide what you are going to do. Either you want to go to transpedicular, or you want to have a Camben's approach. And you see the difference after the injecting the dye. Then you will come to know how the dye is going and how the patient. You do few cases with the subpedicular approach, do few cases with the subpedicular Camben's approach. Then you will feel which is the better, and which type of patients, where there is a pathology, and which type of patients are suited to which approach, you will automatically come to know. Thank you.
Thank you so much, sir, for your wonderful lecture. Now, all of you can proceed to the lunch area for the lunch, and we shall meet again here at 1:30 p.m. for the next CME session. Thank you. Lunch is being organized as room number 309 of Kalam Center. As there is still some time left for lunch, so we can proceed to the next CME session, which will be taken up by Dr. Pankaj N. Surange, sir. To introduce Dr. Major Pankaj N. Surange, sir. He needs no introduction. I have already told about him in the inauguration ceremony. To enumerate his qualifications, he is a fellowship in interventional pain practice from Budapest, Hungary. He is a fellow of Indian Academy of Pain Management, fellowship in spine endoscopy from Korea and Germany. He is the director of Interventional Pain and Spine Center, ISPC India, New Delhi. He is director of ISPC India Training Institute. He is honorary secretary, Indian Society for the Study of Pain. He is ex-chairman, World Institute of Pain of India, Sri Lanka, Bangladesh and Pakistan section. He is the founder, member and treasurer of the Musculoskeletal Ultrasound Society of India. Founder, member and honorary secretary, Neuromodulation Spine Society of India, international member of the Spine Intervention Society. He has been an invited faculty at various national and international conferences. He has 4 editorials and 3 international and 7 publications to his name, 5 book chapters. He is the recipient of Pain Awareness Ambassador Award 2015, recipient of Excellence in Pain Practice Award by World Institute of Pain in 2017. He is a recipient of National Pain Physician of the Year 2016 and recipient of Her Highness Rajmata Sindhya Excellence Award. Now I would like to hand over the mic to Dr. Major Pankaj N. Surange, sir.
Good afternoon to everyone. So, I'm talking about the endoscopic spine procedures. Definitely, this procedure is comes under advanced spine intervention, and I'm sure that this is not a good platform to discuss the technical aspects of the this intervention, endoscopic. So, I'll not go more into the technical details of the endoscopic procedures, but what I'm going to discuss here is that this is one of the procedures what we have in pain medicine now. This is a definitive procedure. Normally, till around 7-8 years back, pain medicine was more of the supportive kind of specialty, but it is not now. Now we have all the definitive interventions available with us where we can actually treat the pain. We cannot just control the pain, we can actually treat the basic disease and we can have a definitive solution for the pain sources. So, we all know about the specialty, pain medicine is a specialty. We just discussed since morning, so I'll not go into details. ISSP is our national body. It's a 35 years old national body, and we have more than 3,000 life members in this national body now. As we discussed that, we have pain medicine become a super specialty now. We have DM in pain medicine, we have FNB in pain medicine, we have postdoctoral courses, 1-year or 2-year courses in pain medicine. And we have just, we also started fellowship certification exam by the ISSP, that is a FIAPM. So MIPSI is the word which is basically is given for the minimally invasive pain and spine intervention. Most of the pain interventions when we do on a patient, most of the patients they come with the spine. That's why we included spine into the pain and spine, the minimally invasive pain and spine interventions. Now look at this. Look at this. I think all of you know that this is an MRI. This is a sagittal section of the MRI, and you can see somewhere that there is some pathology there. There is some pathology here, here. In all the sections, all these 6 pictures what we are showing here, they have some disc pathology there, right? You can make out that these are normal disc over here, and but this is a pathological disc. Everywhere, all the pictures they have a different pathologies. So, as a pain specialist, what options we have? Are we going to treat with the simple nerve blocks in all the cases? No. That's a supportive treatment what we can give. But can we do something definitive to control or to manage these kind of conditions? So that is what the pain medicine is now. We have definitive approaches for different pathologies. So that means whatever pathology is there, first we identify the source, we identify the pathophysiology behind that source of the pain, and then we address that pathology. So that is what the pain medicine is now. So back pain with or without radiation, when we talk about the spinal pain, we have different kinds of source of the source generator of the pain. We have discogenic pain, that is the pain coming from the disc itself. We have facetal pain, as just discussed by Professor Anil Agarwal. We discussed about Professor Agarwal. He mentioned about the biocoplasty. That means if you have a condition like this, we have a annular tear. There is a tear in the annulus in the disc. In that case, we can go for the repair of the disc without just not giving epidural steroids over there, but we can actually repair this annular tear over there with the help of this biocoplasty procedure. We have a back pain with the radiation to the legs. We have contained disc condition. That means the nucleus material is still within the disc material. Or if you have extruded disc, that means the nucleus material has come out of the disc and is but in continuity with the parent disc. And the sequestrated disc where with the nucleus material has come out and it is lying somewhere in the canal. It is migrated upwards or downwards. So depending on the type of the pathology, disc pathology, we can decide our intervention. Like in this case, if we have a condition like this, where we have a small herniation is there, contained herniation is there, hydration is there, is good. In those cases, we can go with the shrinkage of the disc with the help of ozonucleases. If you have a small herniation, hydration is not good, we can go for the mechanical decompression. That means we can create some space inside by removing some disc material from here, and so that the disc can shrink on its own over a period of time. So that is called a disc decompression. If you have a contained herniation, large herniation, compressing the nerve over there, you can see here there's a big herniation and it's compressing the nerve over there. Or if you have a extruded disc, that means the disc material has come out of the disc, out of its parent disc, and it is but in continuity with the parent disc. Or if it is sequestrated, that means the disc material is lying somewhere else in the canal, like this, sequestration. So for these conditions, what we can do? Now, if we have a patient who comes to us with these kind of problems and the patient is having radicular pain, So as Dr. Devendra just mentioned about the transforaminal approach. So if the patient is having only radicular pain, patient doesn't have any neuro deficits, no sensory deficit, no motor deficit, we still have one chance of minimally invasive technique that is called transforaminal. Because this pain is because of the inflammation of the nerve root which is there. Because the nucleus material is lying over there, it is touching the nerve, it is causing inflammation of the nerve root. So in those cases, we can go for the transforaminal approach and we can just inject, go through the foraminal approach, either Campbell's approach or the subpedicular approach as Devendra already mentioned. And we can reduce the inflammation of the nerve root over there. But if we have conditions like these, if you are done with the transforaminal, the patient comes to you with some sensory deficit or some paresthesia, if the compression is so severe, we can see on MRI. In those cases, obviously we have to decompress the nerve. Decompression means we'll have to remove the disc metal from there to decompress the nerve, to release the pressure of the nerve. So in those cases, it is better to go for the spine endoscopic procedures. So this is what we are going to see now, how we can help these patients with the spine endoscopy. So there are different techniques available. There's inside out technique and outside in technique. Whatever technique we use, the idea is basically to remove the fragment from there. So we just saw few MRIs where we have a extrusion of the disc or the sequestration of the disc. Our idea is to remove the fragment which is lying in the canal, which is compressing the nerve root. So before going for the endoscopic discectomy, because it's an advanced procedure, it's a definitive intervention procedure, we must understand the anatomy very, very well. We just can't learn the technique and start doing it, just putting the scope inside and start doing it. And understanding the anatomy is very important because you can see there are so many important structures before we reach to the disc. There are so many muscles over there, fascias are there, ligaments are there, there are multiple vessels are there, nerve roots are there, dura is there. So all these structures are there. Whenever we are going for the advanced procedure, we must understand all these pathologies very well. We must also understand it is not one technique we can learn because every level you can see L1, L2, L3, L4, L5. You can see the difference in the structure of these of the vertebrae. The orientation of these vertebrae are different at each level. So we have to understand this anatomy from starting from the L1 to L1 level so that we know that what is a safe landing position for us to reach that target area. Also, as I mentioned that there are multiple vessels also around there. So bleeding is one of the complications which is associated with this endoscopic discectomy. So there are multiple vessels which may come across whenever we are going for the endoscopic procedures. We must understand and read the MRI very well. Just don't rely on the reports, because now here, when we are sitting in the OPD, we are the one who are deciding the interventions. How we are deciding? We are deciding on the basis of the MRIs and the clinical correlation. So we must understand what are the sources of the pain. We may find multiple sources of pain on MRI, but what we are seeing on the patient is something different. Okay, so this correlation is very important. That is one. Another important thing is fragment. As I mentioned, our target is the fragment. Where is the fragment lying? Until unless we don't know where is the fragment lying, we cannot dodge our scope or the working channel to that area. There is no point of just going inside the disc and removing the disc material from there. We have to target a fragment. That is the most important thing what we have progressed now. So different sections are there on MRI. Coronal sections, sagittal sections and axial sections. We must know how to read all those sections. There are some contraindications, there are some for the endoscopic procedures. Obviously, we cannot treat every patient who are coming with the extruded disc. There are some contraindications for us also. There may be some foraminal stenosis, severe stenosis is there, bony stenosis is there. In those cases, there is a listhesis is there. In those cases, we cannot do. We must know how to read these X-rays also, because this will guide us before taking the patient inside the OT under fluoroscopy guidance. We must know how to read an X-ray also, because this X-ray will guide also us that how to go, what would be my approach when I take the patient inside the OT, whether I can go to the foramen or I have to go for the interlaminar approach. So as I mentioned, the listhesis is one of the contraindication for this endoscopic procedure. Now look at this MRI. You can see the same patient, 3-level disc pathologies, but here we can see there is hardly any bulge, but there is a tear there. here we have an extruded disc. Here you have a contained disc herniation. Now suppose my pathology is here. Suppose I think that the source of the pain is this. My target would be something different. I'll not go for the endoscopic discotomy in this case. I'll try to repair this disc over here. If my target is here, at this level, if I think that this is the source of the pain, I'll target the fragment over here. I'll go outside in. I'll rightly go into the canal and I'll target this fragment over there. If I think that my target is this, I'll go inside and I'll try to remove it from inside without disturbing the annulus, because the annulus is intact over here. I'll not disturb the annulus over here. So this is what I'm telling you, that it is a target specific. These are all target specific procedure. We must understand the anatomy, we must understand the pathophysiology and the MRI very well before we decide endoscopic. So depending on the type of the herniation, whether it is a central herniation, it's a paracentral herniation, it's a foraminal herniation, or it's a extraforaminal herniation. Now we have to go for the different approaches. As I already mentioned, the idea is not to go inside the disc in all cases. We have to see where is the fragment lying. So for different kind of herniations, we have to target, we have to go in different approaches. So there are different approaches like this. If you have a upward migrated disc or it's a foraminal disc, in those cases we can go for the exiting route approach. If we have a paracentral herniation or if it is migrated downwards, in those cases we can go for the traversing route approaches. Like this. This is extraforaminal approach for the lateral disc, transforaminal approach, and this is the interlaminar approach. So interlaminar approach is basically for the conditions, especially in the L5-S1 region, where we have a sequestration of the disc. If it is lying in the foramen, we can go to the foramen and we can take out the disc material from there. But if it is lying in the canal, it is lying in the central canal, or it is a median extrusion is there. In those cases, we have to go through the interlaminar space and we can remove the disc material from there. I'll just show you some cases so that you can understand what exactly is that. This is the case of L5-S1 extruded disc where we did a transforaminal approach. You can see here. Now I can see that the nucleus material, whatever is the extruded material is there, it is lying into the canal and it is going into the foramen and going to the canal over here. So in this case, although it is a L5-S1, we can go to the foramen and we can target this. Also here I can see that in the coron section, I can see that it is, what is the relation of this extruded material in relation to the nerves, exiting route or the traversing route. So this is how we saw that the material was lying over here. So what I'm doing is I'm just going through here. I'm not going inside the disc over here. I'll just go over here and I'll target the fragment over there directly. So this, how you can see, this is a guide wire which goes inside first. We go inside with the guide wire. We locate the extruded material. We inject the contrast. We see that we are just into the extruded material over here, and you can see the contrast is going inside because we are in the extruded material which is lying in the canal. This is how we can put a dilator, and over the dilator we put a scope, the working channel. So you can see here. So as you saw on the MRI that it was lying in the foramen and also in the paracentral area, so I just dodged my working channel over there in the foramen and the lateral recess area. And this is how we can. So this is what I saw immediately when I entered it, because I knew where is the fragment lying. So you don't have to do too much of searching of the fragment in such cases. Until unless you don't know, you will go inside, you will start taking out material and you will start searching the extruded material. But if you know how to read the MRI, you will directly land up into the extruded fragment over there. So this is how we can see, this is what we have cached a fragment over there. And this is how the fragment has come out. You can see there's a big fragment over there. That's a fragment. So this was our target. So what we have done is we have not disturbed the entire disc. We have not done any nucleotomy, we have not done any annulotomy, or we have not cut the annulus anywhere. We have just targeted a fragment and we have removed the fragmented part. Again, another case, you can see there's a big extrusion over there. It is migrated slightly upwards over there. It is lying mostly in the foramen. So I just targeted the foramen without entering into the disc, and we just removed the nucleus material from there. You can see this, that's the foraminal area from where we have found our extruded material, and we are trying to remove that from the foramen. This is again a big chunk of the nucleus material which comes out. Look at this. So this will immediately decompress the nerve. Whatever the nerve is compressed, we had to decompress it with these kind of endoscopic procedures. This is another case we can see here. There's a paracentral herniation over here. There's another big herniation over here, and this is a post-operative MRI of the same patient. I don't have the videos of these MRIs procedure. This upward migrated disc. In this, we approach the exiting road approach, and then we have removed the disc material that is clear from here. Complications, yes. We must understand when we do any interventions, we must know the complications first, and we must know how to deal with them. Until unless we don't know the complications. So that is why it is important to work with somebody for few years before landing, before going for these kind of interventions. It is always better to take a good experience with some experienced physician and work under them and then start doing. Because you may learn the technique, but what you are going to miss if you are doing it in a very in a haphazard manner, what you are going to miss is that how to deal with the complications. So that is the importance of the long learning curve. So these are the complications which may occur. We know that for any intervention, since we are going inside into the canal, we may land up into complications. So nerve injury or dysesthesia is one of the complications which may be associated, because when we go to the foramen, there are chances that we are compressing the nerve for some time, exiting route is there, which is coming to the foramen, and when we go into the canal, our working channel is there. That may compress the nerve, and that may lead to some dysesthesia for some time. Recently, just a few days back, I had a case. The patient had come from Bihar, and he landed up with some such complication. So we had to admit the patient for additional 3 days. This patient had a post-operative, he had a motor loss. So this motor loss was not a direct insult, direct injury to the nerve, but it was because of the dysesthesia, because it was a difficult case. So I took a longer time. I took more than 2 hours to remove this nucleus material from there. And because of that compression over the nerve, it leads to the dysesthesia. So post-operative patient was having some weakness in the leg. So I had to admit the patient for 3 days, but patient recovered. Usually these kind of injuries, compressive injuries, they usually recover. Reherniation, chances of reherniation are there, especially when you are doing annulotomy, when you are removing the annulus, when you are cutting the annulus. In those cases, chances of reherniation are there. So we must know what to advise post-procedure. That is again very important. Although we can discharge the patient same day, but we must explain them the importance of wearing the lumbosacral support belt, the importance of avoiding some activities. That is most important in such cases. Bleeding, as we know that there are some vessels which are there which goes to the foramen. So there are chances that we may land up into some bleeding. Most of the bleedings are usually venous bleeding, and we can control with the radiofrequency. But if there is some arterial bleeding, that at times become difficult to control. I had a case of bleeding where we had to open the case. I was doing interlaminar. There was a bleeder. There was an artery over there. That was an enormous artery which was there. The moment I entered inside, the patient was bleeding inside. So probably what had happened, that interlaminar, there was an artery over there. We cut that artery, and the artery got retracted inside, and it was behind the lamina. So patient started bleeding. I was putting my scope. I could see that bleed over there. I could see the bleeder over there, but I just couldn't control because it was inside the lamina, because it has got retracted inside. So in that case, we actually had to open the case. Discitis, because infection is one of the complications with any intervention, especially with the disc. It is very, very important that you must take all assertive precautions, because disc infection or discitis is one of the complications which may disturb you for long. These patients are not going to, discitis is not going to heal in a few days or few weeks. It may take months to year also. So for that entire period, patient is going to disturb you. Okay, so we must understand this complication, and what is important here is that whenever we land up into any complication, we must accept that complication. Never try to hide any complication. The moment you try to hide a complication, you will end up in more into problem, because if you are hiding the complication, you are not managing it. If you have identified the complication, if you are managing the complication, nobody can punish you. because complications may happen with any interventions, with any procedure in medical, right? So managing a complication, if you identify the complication, if you are managing the complication, it will not land up into, you will not land up into any problem. But if you not identified the complication, if you are not managing the complication, that becomes a negligence. And that may lead to some medical legal issues with you. So we must understand these complications, we must identify this complication, and we must treat this complication. So whenever you have any complication, remember this thing, write a proper history and endorse it, write down the complication that this has happened, accept it, and try to treat that complication. And then start involving other consultants also into that. Durotomy, there are chances because duro is very, very close to the foramen and nerve roots. Even the nerve roots, they have dural sheath over there. So there are chances in the endoscopy that you may land up have a dural tear over there. ICP raise, that is a possibility because here we use a lot of irrigation fluid. Continuously we are using irrigation fluid. So as we know that all of you are anesthesiologists here, we know TURP, right? What happens in TURP? Overloading. Similar things happens in the endoscopy also because we are putting an irrigation fluid inside the epidural space. There are good chances that there may be overloading of the fluid and that may increase the intracranial pressure. Usually these patients we do in a local anesthesia. So that is a very big advantage with us that we do on all the procedures under local anesthesia. Patient can tell you that I am having some neck stiffness or some heaviness in the head. In those cases, you must suspect that there is an increased intracranial pressure and you should be stopping the procedure over there. Bowel injury is although very rare, but in this we have seen cases happening of bowel injury in a very young pain physicians who have started doing these endoscopic procedures. In those cases, they may have gone through or they have gone anterior to into the peritoneal space and they have injured the bowel. So these are the multiple complications which may happen. So, but what is important to understand here is that don't be afraid of the complications. Don't be afraid of the complications because complications are going to happen. If you are doing something, complications are going to happen. If you're not doing anything, you are okay. No complication, no work, no complication. But if you are doing something good, if you are doing volume, you will land up into complication and this complication will teach you a lot of things. So don't be afraid of the complication. Try to manage them as far as possible. Okay, thank you.
Thank you so much, sir, for such an informative and interesting lecture. Now we shall be felicitating all our guest speakers for today's CME. To begin with, Dr. Major Pankaj Surange, sir, will be felicitated by our organizing secretary, Dr. Manish Singh, sir. I request Professor Sarita Singh ma'am to kindly felicitate Dr. Anil Agarwal, sir. I request ma'am to kindly felicitate Dr. Sujit Gautam, sir. I request Manish Singh, sir, to kindly felicitate Dr. Deven Singh, sir. I request Sarita Singh ma'am to kindly felicitate Dr. Shivani Rastogi, ma'am. I request Manish Singh sir to kindly felicitate Dr. Devjyoti Datta sir. I request sir to kindly felicitate Dr. Amitesh Pathak sir. Thank you so much, everyone. Now we can proceed to lunch for room number 309.
Good afternoon all to the post-lunch session of the CME. Welcome back. Myself Dr. Abhishek, SR in the pain unit of Department of Anesthesia. Now I know as all of you post-lunch will be feeling a bit of sleepy, but I am very assured that the next following lecturers who, with their knowledge and their experience will improve your GCS so that you will be all conscious and worked up. So our very first speaker of this session is a prominent name in the field of pain and palliative care medicine, Dr. Sujit Gautam sir. It is my privilege that he is also my teacher and mentor as well. And sir is additional professor in the Department of Anesthesiology in SGPGIMS Lucknow. Sir is managing chronic and cancer pain in the pain and palliative care clinic. Sir has done his PDCC from IMS BHU. And sir has a number of international and national publications to his name, also 6 book chapters, and area of interest is chronic pain management. Welcome, sir.
Well, good afternoon, everyone. Thanks, Abhishek, for the introduction. Well, he said कि GCS आप लोगों का improve हो सकता है, but during lunch, what happened that Anurag boss took us all to the chalk. We had some lassi and chola bhatura. So I am not sure of my GCS only at this point of time. So I don't know what about your GCS is going to happen. So, okay, first of all, thanks to the organizers and Dr. Sarita, Dr. Manish. And approximately 2 weeks back, I suppose, when Manish and I had a discussion that which topic should I take on. So, Manish said that 2 topics, there are somewhat tricky. So, one is facial pain and another is CRPS. So, I straight away told that CRPS I'm not taking. Facial pain, the thing was that I was trying to read it myself as an approach for quite some time, because there are many conditions which give rise to facial pain, and it's somewhat tricky to build up an approach, and rather a simplified approach. So I took that topic, but somehow I could concentrate on this topic for the last 3 and 4 days only. So let us see that how much this approach, which I shall be discussing over the next around 20 minutes, is going to be useful for you. Well, it's pain in the area bounded by eyes and the lower mandible, including oral cavity. And interestingly, this could be the face of the patient and also the clinician who is going to evaluate a patient of facial pain. So there are so many conditions. One clinician could also be in a similar situation. So little bit about the epidemiology. Prevalence is around 2%, more common in the females. And these are the risk factors. I suppose majority of the pathologies, or rather in pain, these risk factors do help us. Now, facial pain do arise from a number of structures in the face. And it is because of this reason that patients from facial pain visit a number of specialties. People go to various physicians for their treatment, and neurologists are the most common ones, and these are the usual conditions with which patients with facial pain go to the neurologist. Now, ENT surgeons are also the specialty to which many patients go. These are the common conditions. And dentist also, these are the conditions. So I thought develop an approach keeping in mind that to which specialty a patient is going, or from which specialty patient is being referred to a pain physician, because there are very few conditions from which patient in which patient comes directly to a pain physician. There are few. Now, these many associations have put forward a classification. So there are many organizations which have put up classification of the facial pain. So different societies putting up classification for the same situation, so there is a confusion regarding the taxonomy. So for the sake of simplicity, I thought it would be useful if we can concentrate on one society, the classification wise. So international headache classification given by the International Headache Society. So, but practically speaking, it's really difficult to learn and apply, more importantly, application of this classification on the patients, because what happens that in classification, few things which I always tend to forget is that duration and frequency, something regarding which is important regarding the diagnostic criteria. So I thought, why not develop a practical approach with the help of which, based on their clinical features, we can concentrate on simple those clinical features and the application part improves. So let us see. So this is how the classification of trigeminal neuralgia and its symptomology or the diagnostic criteria appears when we look the ICSD or International Cranial Headache Disorders appears like. So somewhat complicated, I thought why not simplify it. So neuralgia is a condition, if we consider for trigeminal neuralgia or any neuralgia, where there is electric shock-like pain along the distribution of the nerve, and in most of the conditions there are some trigger factors. So this is the basic presentation of any patient who is going to suffer from any neuralgia. So trigeminal neuralgia is one. The important point is that the duration of pain is less than 2 minutes. And trigger factors, these are the trigger factors one need to take care in its mind. Now, it could be classical, it could be secondary, it could be idiopathic. And classical and idiopathic variants may have continuous concomitant pain. That is, in between two episodes, two paroxysms of pain, there could be continuous pain. So it could be in classical and also in idiopathic. In the secondary, the clinical features vary depending upon the cause of it. So in classical, there is neurovascular compression giving rise to atrophy and displacement of the nerve in MRI. So this is what classical trigeminal neuralgia is. In secondary, as I have said, there could be multiple causes. And in idiopathic, there could be neurovascular contact, but atrophy or displacement secondary to this contact is not there. So this is the basic differentiation between various categories and the important clinical presentation of trigeminal neuralgia. Now, another similar condition is painful trigeminal neuropathy. But the important thing to understand is that it's a neuropathic pain condition resulting from neural damage, and similar for a trigeminal thing also. So any condition which is giving rise to any damage to any division of trigeminal nerve is going to give rise to you painful trigeminal neuropathy. The symptoms are simple to understand: burning pain along one or more distribution of the distribution of one or more division of trigeminal nerve. And there may be some intermittent pain paroxysms which are going to occur on the baseline of some burning episodes of pain. And you may find some sensory deficit because there is the episode of neural damage, so sensory deficit is going to occur. So what are the conditions? The conditions are because of herpes or post-herpetic, then after trauma also, and many times after dental intervention. Then some other disorders like neoplasm in vascular and inflammatory causes, and in idiopathic causes when no cause can be identified. So these are the conditions which may give rise to painful trigeminal neuropathy and the clinical presentation. So now if we look at glossopharyngeal neuralgia, basic symptomology is going to be the same. The only differentiating features are these, that what is the area of pain, that is over the glossopharyngeal nerve distribution, and these are the factors which are going to precipitate this thing. So this is how it differentiates from trigeminal neuralgia. Now, similar to trigeminal neuropathy, there is glossopharyngeal neuropathy, burning pain over glossopharyngeal nerve distribution, along with intermittent pain paroxysms. Now, this term was something new when I read this time regarding the facial pain. And we used to know it as atypical facial pain. So persistent idiopathic facial pain is the description. And there is persistent facial and oral pain, which is dull aching and poorly localized, along with intermittent exacerbations. And the important differentiating feature with the previous neuropathy is that it doesn't follow a nerve distribution. So it occurs, it is occurring over the face, but it doesn't follow a specific nerve distribution. And few important factors is that neurological examination is normal. You are going to find sensory deficit in case of neuropathy, but here neurological examination is normal, and it is very commonly going to be associated with stress. Now, condition which comes in this PIFP is also atypical odontalgia, where there is continuous pain in a teeth or in a tooth socket after extraction. However, there is no dental cause which is present. Though there is history of tooth extraction is there, but there is no dental abnormality which is present. Now, burning mouth syndrome. There is intraoral burning sensation with normal oral mucosa. Some facts: pain is bilateral, and most common site is tip of the tongue. It may also present as dryness or altered taste to the patient. Now, something regarding temporomandibular joint disorders. I've been trying to read this thing for quite some time, but we usually get patients which are complaining like some clicking sound or pain over the trigeminal trigeminal joint. So it is group of musculoskeletal disorders involving TMJ and the masticatory muscles. And this is quite an interesting article. I feel I couldn't go through it entirely, but definitely if one wants to gain some understanding, this is an interesting article. And the presentation is like unilateral facial pain in preauricular area over the temporomandibular joint. And the pain is dull aching with intermittent exacerbations, worsened by movement or palpation of temporomandibular joint or the surrounding masticatory muscles. So pain in this area, along with which is aggravated by movement or palpation of the joint or the muscles which are there. So these are some common symptoms which are associated. And now coming on to this giant cell arteritis. It's a red flag, first of all. We need to be careful, and the diagnostic criteria is mentioned over here. And most commonly, these patients come to an ENT physician, ENT surgeon. From there, patients might be referred to us in case of inadequate diagnosis being made. So we need to take care of it. And the treatment is high dose steroids. The important thing about the pain is that pain is non-specific, and its location is either in the temporal area or in the temporomandibular joint area. And one clinical feature is that patient may complain of pain over the masticatory muscles after chewing, after a long duration of chewing. Now, cervicogenic headache is one entity, the patients of which may come to a pain physician directly. So, as the name itself implies, it's a headache because of some structures which are present in the neck. Now, the diagnostic criteria given by the ICSD is somewhat different. There are two or three organizations have given the diagnostic criteria. One is the International Cranial Headache Disorders, and the other is CHID, the Cervicogenic Headache International Study Group. The two are somewhat different. These two are most commonly followed classification, and these two differ. So this article has given some features which are suggestive of, and we may apply to while making the diagnosis of it. So unilateral headache without side shift. That is, headache is present on one side, and it is on the same side on which the patient is going to complain pain in the neck. And two additional features which are important. One is that headache is provocated by neck movement or pressure over the muscles which are causing the headache. And more importantly, it is going to be abolished by anesthetic blockade or cervical structure which is giving this headache. That's particular structure or nerve supply. So these additional features which may be present autonomic symptoms, nausea, vomiting, photophobia and phonophobia as seen in conditions of migraine. Now the common sources, third occipital headache from the C2-3 facet joint, atlanto-occipital, atlanto-axial joint and cervical muscles. Little bit about the referral pattern of the C2-3 facet joint, which is most common cause of cervicogenic headache in the occipital, suboccipital area and the fronto-temporoparietal area. Then regarding atlanto-occipital, atlanto-axial joint in the occipital, suboccipital area along with eye and ear. So this is the referral pattern. Now these are the referral patterns commonly seen with various muscles for the temporalis over the temporal area and in the cheek. Trapezius, as you can see, occipito-temporoparietal and also over the eye. Then sternocleidomastoid may give pain all over the face, referred pain all across the face. Now finally, that's all. 2 or 3 more slides. I suppose we are getting some nice sleep post lunch, so this is the most ideal time to fall into sleep. So TAC or trigeminal autonomic cephalalgias. It's, as you can see in the figure, it's unilateral headache along with cranial autonomic symptoms, to which I am not going into detail. And there are 5 conditions which are associated with this trigeminal autonomic cephalalgias. And definitely when there are conditions, 5 different set of classifications are also there. So I thought, why not pick out some individual feature which is going to help us make diagnosis towards a specific pathology. So, sorry. What is happening? Okay, yes. So cluster headache. Pain occurs in clusters, as the name itself implies. Clusters of weeks or months followed by period of remission when there is no pain. And a very peculiar feature of this cluster is that it occurs most commonly in the period of night after falling asleep for a period of 1 to 3 hours. And very severe pain. And this is one of the few conditions which is more commonly seen in males. So most of the conditions either have got a similar distribution or more commonality in the females. Now, SUNT or SUNA, their full form is short lasting. The S is for short lasting. That's other letters you can read in the description given below. So, as the name itself implies, short lasting or for seconds. The pain occurs for seconds and in a sawtooth pattern, as we usually see a graph of tetany. So something like that, or multiple stabs are there of severe pain. So that is the specific feature for this. Now, paroxysmal hemicrania. These paroxysmal hemicrania continua are somewhat similar in the sense that both have got sense of restlessness and responsiveness to indomethacin. For paroxysmal hemicrania, there are paroxysms lasting for less than 30 minutes. So within 30 minutes, there are paroxysms, but not lasting more than half an hour. For hemicrania continua, there is persistent pain. Persistent pain for more than 3 months with intermittent exacerbations. So this is how these 4 or 5 conditions could be differentiated. So to conclude, these are the conditions which I have discussed so far in this presentation. So take home, when assessing facial pain, the first and most important step is a thorough history leading to a possible differential diagnosis. Next, the neurological examination might reveal directional signs. Finally, some investigations to confirm that diagnosis. And the red flags are giant cell arteritis and orofacial cancer. We tend to take care of these 2. Thank you very much.
Thank you so much, sir, for a very informative talk on facial pain. Now to take the topic further, I'm going to call on stage our very dynamic and enthusiastic Secretary of ISPC, Dr. Anil Agarwal, sir. Sir will be discussing about trigeminal neuralgia. Sir is PDCC from Pain Medicine and FI APM, pain spine physician and professor in the RML Institute of Medical Sciences, Lucknow. Sir is a member of Pain Medical Board and National Board of Examinations, Honorable Secretary, Indian Society of Pain Clinicians, Founder President, Endoscopic Spine and Interventional Pain Society of India, Vice President, UP Chapter of NAPCAN, member of Ethics Committee, Cancer Aid Society, and sir has more than 35 national as well as international publications. Welcome, sir.
Don't get confused by the topic, it has already been covered. So I will just skip few slides by Dr. Sujit Gautam. Thank you, Sarita ma'am, dear Manish, Dr. Chaudhary for having me here. As I promised, I will be here again, so I am. We will go directly to this slide. Why most of you are from anesthesia background? Yes? Okay. So this is a super specialty for you. Our societies, both societies, ISSP as well as the ISPC, that is, one is Indian Society for Study of Pain, another is Indian Society for Pain Clinicians. These both societies are working very, very hard to have a super specialty branch for you guys in the future. If some of you perhaps may find that coming out of OT, coming out of the shadows is your choice in the life, so it will be one branch where you can actually come out of the OTs and ICUs and work and behave directly with the patients. So it evaluates, as you must have understood by now since the morning, it evaluates and treatment, not only manages. We are not managers, we are clinicians, we are physicians. नहीं अभी चेंज करें नहीं ना, वहाँ भी चेंज नहीं हुई क्या? तो वहाँ से कैसे होगी? किससे? इससे चेंज करना होगा. ओके. अभी भी नहीं करो. Okay. So sorry, I didn't know. So it is the treatment of the cause most of the time of the chronic pain conditions, which can be anything starting from the facial pain to back pain to neck pain to joint to spine to slip disc to vertebral collapse to sciatica, anything. And it requires that you at least get trained for 1 year or actually for 3 years. You took or you are going to take 3 years to learn how to give a spinal, how to put a tube, endotracheal intubation and doing the ventilatory thing. So that way also you need to have a training, proper training at least for 1 year and optimally for 3 years. Now the opportunity is there in the form of DM pain medicine. Perhaps your institute will be another one who will be having a DM course for you. Now what is MIPSI? Dr. Pankaj has already described it. It is a minimally invasive procedure to diagnose and treat the pain generator, the cause of pain. Most of the time we do it under X-ray guidance, that is fluoroscopy, or sometimes ultrasound guidance. Charging खत्म होने वाली है, चल जाएगी I think. नहीं charger नहीं है. So benefits हो गए. Facial pain syndrome already it has been beautifully covered, far better than me by Dr. Sujit Gautam just now. So today we are here. My topic is here one of the reason because it has been talked about too much about this man who is suffering from this condition. And this condition is not a new one, though the modern media has come to know about it. बंदी हो रहा है तो बिल्कुल. चार्जर होगा नहीं? इसका तो चार्जर नहीं होगा. नहीं, मेरे पास पेन ड्राइव में है, अगर कम काम कर जाए. नहीं बेटा, एप्पल नहीं है. वो सुबह से खोल के तुम्हें दिया था ना, तब से खुले ही रह गया. अरे वाह, क्या बात. हुआ हो रहा है. Okay, so the term is came into existence in 17th century by the Nicholas Andre. And what I want from my lecture, that all of you, when you go from here, you must make a spot diagnosis of trigeminal neuralgia. You must not miss a patient of trigeminal neuralgia if you encounter one. So you already know about the definition, but I am going to show you some patients. Sound? दोस्त साउंड. मैंने बोला था ना साउंड है बेटा इसमें. साउंड इसमें नहीं आ पाएगा. तुमने तो सुबह से बोला हुआ था दोस्त. ये तरीका होगा. मुझे क्या पता कहाँ है. तुमने तो सुबह से बोला था बेटा. कहाँ से आती है? कुछ आवाज आ रही है? कितने? So sudden unilateral severe brief stabbing recurrent pain in the distribution. Another patient. कहाँ दर्द हो रहा है बताओ? किस तरह का दर्द हो रहा है? किस तरह का? करंट जैसा लग रहा है? बहुत तेज मार रहा है. कितने साल से बेटा दिक्कत है तुमको? 2014 से 7 साल. So I hope that when you will encounter another time a patient of this condition, you will be able to make a diagnosis. Because why I am saying so? Because unfortunately many of these patients are coming with a missed diagnosis for 10 years, 15 years, 20 years. Many of them have lost complete denture. जिस साइड का पेन है, suppose it is V3, so they have lost 8 tooth. That means that he has at least visited 8 dentists. Everybody has removed one. So that is so unfortunate. That आज 2020 में 22 में खड़े होकर हम लोग डायग्नोसिस नहीं बना पा रहे हैं, forget about the treatment. So that is really pathetic. Epidemiology already you know, slightly more common in the female, familial in 4 to 6 cases. This correlation of incidence with age, again now I find it actually more of academic rather than the reality. We have got patient of 13 years, we have got patient of 21 years, we have got patient of less than 50. Currently perhaps most of the patients are मैम जो हमारे पास आ रहे हैं वो less than 50 वाले हैं and उनकी history 20-20 साल की है. So this is perhaps not the right data, but it is from the books. And now I know the cases where it is absolutely familial. I have come across a group where there is a lot of trigeminal neuralgia patient. Mother ko tha, now the daughter is also having in the age of 15 years. We don't know the reason. Classification already has been covered by Dr. Gautam. Most of the time, again, there is a lot of confusion, different societies, different classifications, as is the case with most of the things in allopathy. So, vascular compression, most common anatomical finding, which is considered to be culprit by most of the authorities. But if you talk to radiologist friend, they will tell you, sir, we very often see aberrant vessel on the trigeminal neuralgia while we are doing the routine brain scanning. And those patients are not having any trigeminal neuralgia. So, if it is there in a patient of trigeminal neuralgia, it could be a cause. But if it is otherwise also there might not be any trigeminal neuralgia. So, again take it on the face value. So, this is, I have already told you, another patient I would like to show you.
कहाँ से शुरू होता है दर्द, कहाँ जाता है?
There is a trigger point on the upper lip and it is getting silenced. It is coming, it is going.
खाना खाने से भी होता है? बोलने से?
This last line is very important. Pain-free interval between two attacks is a feature of classical and idiopathic trigeminal neuralgia, that is type 1 trigeminal neuralgia. There is one more classification, that is Burkill type 1 or type 2. Type 1 where there is only electric shock like current. Type 2 where there is shock like pain but there is a baseline pain also. So, for us pain physicians, it is very important if the patient is having type 1 neuralgia or type 2 neuralgia, because type 1 responds beautifully for our interventions, type 2 doesn't. So, that again becomes, already know, never crosses midline, that is a truth. I haven't seen patient having pain crossing to line. I have seen patient, I have got a patient who is actually a pediatrician doing SR ship. She is having bilateral trigeminal neuralgia. One side she has undergone MVD, another side she is going to come for the balloon compression. So, anatomy you already know, trigeminal roots comes from the pons, goes through the porus trigeminalicus into the Meckel's cave. From Meckel's cave there is a gastrin ganglion. It divides into three parts. One is coming from the superior ophthalmic fissure, second is coming from the which foramen? I think rotundum, rotundum, and third is coming from the ovale. So, ovale is the route which we all employ to reach the Meckel's cave and doing our work. We will come to see. Treatment start with the carbamazepine. It is so much so that if the patient is not responding to the carbamazepine, perhaps it is not a trigeminal neuralgia. It is a drug of choice and it is also a diagnostic feature. If you are having some doubts, please prescribe carbamazepine. If the patient responds, it is a trigeminal neuralgia thing. Then other so many drugs, churan chutney, gabapentin, pregabalin, maxilitine, lot of anything you can try, whatever under the earth. Then comes the surgical treatment, which is considered to be the gold standard treatment till now, especially the young patients with the evidence of aberrant vessel on the MRI, that is microvascular decompression, also known as Janeta's procedure. Then comes the gamma knife, that is radiosurgery. Both are available in India, both have been done beautifully and routinely. And now comes our role as a pain physician. They are minimally invasive pain intervention. First is radiofrequency thermocoagulation, second is balloon compression, and third is glycerol rhizolysis. Actually, this sequence is wrong. The first thing which started was the glycerol rhizolysis way back in 70s, rather 60s of last era. Then came the RFTC, that is radiofrequency. Then the newest kid is the balloon compression. But currently, most commonly performed procedure for the trigeminal neuralgia is radiofrequency and balloon compression. So, all the percutaneous approaches use the transovale route. Again, not a new thing. In 1912, Dr. Hartel described this route to the world, that you can reach the Meckel's cave employing this route. They used to do it with the landmarks, anatomical landmarks. They were greats. They didn't have any imaging facilities. They were just using landmarks to reaching there. We also use this route, but we use C-arm fluoroscope to be precise and to have lesser time. Thermocoagulation radiofrequency also introduced was in 65 by Dr. Sweet. Here we take a fine cannula, reach to the gastrin ganglion, make a lesion in the particular part of gastrin ganglion which from which the pain is coming. Suppose it is V3, we try to find the part of gastrin ganglion which is supplying the V3 branch. Then comes the glycerol, again 81. But before that also they were doing a lot of glycerol thing because it is quite cheap but cumbersome. It is non-specific to the branch. You cannot target one branch, suppose V3, V2 or V1. It is non-specific thing. Then comes the balloon compression. In 83, first time Dr. Mullen and Dr. Lister, these were two people who actually described this technique where we go use a Fogarty balloon of 4 French and compress the gastrin ganglion against the bone of petrous temporal bone, and we create a lot of pressure to disrupt the pain cycle. Indications for percutaneous interventions are failure to adequate medical management. Suppose patient is having a lot of sedation, side effects due to carbamazepine and gabapentin and baclofen and still not getting relieved. General health is poor so that patient cannot or not willing to go for open surgery, that is microvascular decompression. So these are the common indications, but now the things have changed in last 5 years. Now European Association of Neurologists, they have put balloon compression at par with the MVD. That is the latest thing which has happened last year. So they have studied the efficacy and the side effect profile of both the procedures. So now they are at par. The advantage of radiofrequency is that is very effective, is safe, high immediate pain relief, easy repeatability, because there is an incidence of 20% almost recurrence over the 5 years, irrespective of therapy, both with MVD, with radiofrequency, with balloon compression and other things. So, but there are a few disadvantages like paresthesias and dysesthesias can be there. There can be decreased corneal reflex, especially if you are trying to target the V1 ophthalmic division. When the patient is, I saw you one young patient, male patient who was complaining of pain here. So in that patient is not a good candidate for radiofrequency because there are chances of corneal anesthesia. Then comes anesthesia dolorosa, bad thing, but all these things you will learn when you, if you opt for pain medicine later on. So there are a few representative pictures. Here you can see this is a specialized view of C-arm where you can see this is the foramen ovale and this is the radiofrequency cannula. And this technique is known as gun barrel view, where you see a 10 centimeter long cannula just as a dot. I hope you can appreciate. This is just a dot. So this is gun barrel technique of cannula placement. And here this is a lateral picture and we are in the Meckel's cave. This tip is in the Meckel's cave and in the gastrin ganglion. So after that we do a sensory motor stimulation and patient usually are very happy after that.
मेरे लेफ्ट साइड में बहुत झटके आते थे, न तो कुछ खा सकते थे, न पी सकते थे, जबान भी लेफ्ट राइट हैंड हमारी में 2 मिनट टच करना भी मुश्किल था, फिर सब बिल्कुल
चीरा टाका तो
नहीं, ऐसा कुछ भी नहीं. अब जो भी हम
This patient actually is a veteran from the armed forces. He has undergone 8 craniotomies for different reasons and for microvascular decompression also, but unfortunately he landed into trigeminal neuralgia and he responded beautifully with the radiofrequency. Another patient, ये भी after radiofrequency. बताइए दादा, कल आपका इलाज किया था झटकों का, तो उसमें कितना अंतर है? 50% से अंतर है. कल तो बहुत झटके लग रहे थे, आपका चेहरा भी टेढ़ा हो रहा था. अच्छा, कल जो हमने किया इलाज रेडियो फ्रीक्वेंसी, उसमें तकलीफ तो नहीं हुई आपको कुछ? अच्छा अच्छा, चलिए अपना ध्यान रखिएगा. ये वीडियो हम देख. Good part is that you can see that there is no scar mark. Patient is completely conscious oriented and it's actually a day care procedure. We put them for the overnight watchfulness. That's it. Then comes the balloon compression. Here you can see the balloon and this is a 14 gauge cannula. Again we use the transovale route described by Dr. Hartel and reach the Meckel's cave, compress the gastrin ganglion. Here is a small video of the procedure, but perhaps it will be too long. So good morning. Here we are going to demonstrate percutaneous balloon compression. You can see the ovale, the C-arm fluoroscope guidance. This is our patient of today only, and here you will see. And this is the cannula. This again the gun barrel view. I hope you can appreciate this gun barrel view. here you can see it is reaching a Meckel's cave and
We have
Fogarty
reached
catheter of 4 French, that it is there, and now we are going to inflate because 82 balloon has taken a shape of pear, and this is 1 ml. So only 1 ml dye does wonder in this case. This is good morning. We are going to demonstrate. Sorry. This is just a small GIF. It is more useful perhaps to understand what we do. Here you can see the foramen ovale. Needle is going for the local stab incision. 14 gauge cannula. 14 gauge cannula. Lateral picture. You see the guide wire going in, then the balloon going in. And balloon is getting inflated, taking a pear shaped balloon. So this is how we do the balloon compression, and it is really an effective technique for many patients. This is one patient which I would like to show. He was suffering. बताइए दादा, क्या नाम आपका?
ये 1966 में हुआ था.
1966 में. फिर उस समय. So at that time he is now 70. 1966, 1966 he was made a diagnosis of trigeminal neuralgia. So he has practically spent his life with this disease, and everybody was treating him. This patient actually taught me something which was not written in the books, that there can be some silent spells also. Then he was suffering from more than 50 years, but there were like 5-year period when he was having no pain, or 6-year periods in between. Then one fine day it starts, and it starts badly. So it always happens. It also happens, and this is just after 1 day of balloon compression. तो कल आपका दादा हमने जो ट्रीटमेंट किया उसमें आपके पास से आप कैसे हैं? अच्छा, करंट लगना बंद हो गया चेहरे पर. So perhaps this patient was one of the longest history of trigeminal neuralgia recorded patient, and you see the diary he has maintained. I took a photograph of it. 1966, 8 AM, 100 झटके लगे बिजली के. So he has beautifully recorded all his diagnosis and symptoms. Another patient, you can see, just you can see. He's having less of pain, but more of the facial twitching and pain.
अभी नॉर्मल होगा, अभी मेरे को कोई तकलीफ नहीं सर. अच्छा. बिल्कुल जीरो है बैलेंस, कोई.
बिल्कुल ठीक हो गया.
हवा में दर्द उठेगा, हवा में खत्म.
कहाँ से शुरू होता है दर्द? कहाँ
दर्द यहाँ से कान से ये पराएगा सर ऐसे, यहाँ से, और उसके बाद यहीं से दर्द इसको छूने से.
And next after balloon compression.
बताइए
कैसा दर्द है?
ठीक है सर.
पूरा आराम है? अच्छा, और क्या लग? राइट साइड में भारी भारी लग रहा है, वो ठीक हो जाएगा. Some numbness, hyposthesia in the
बताइए कैसा दर्द है?
territory, involved territory, it happens. So balloon compression is useful in both elderly as well as young patient. There is slight permanent sensory loss in most of the patient, but it gets better by 6 months. Technically is why? Because we do it under general anesthesia most of the time, where we do not require patient's cooperation. For radio frequency, you need to have your patient awake. Disadvantages are there, like the mesenteric weakness, which again gets better with time, and then there are infection, which always there is a chance. This is one paper we have published of the percutaneous balloon compression, and this was the media coverage we got for that particular patient I showed you, more than 50 years of age. And actually this coverage helped us. Actually in anesthesia we never talk about the market and business and the marketing, which is actually not required because someone else is hunting for you and you are getting a share of it in the mainstream anesthesia. But here in the pain medicine you have to hunt yourself, you want to feed yourself. So this kind of publicity brings you the patient from across the any place the patient come, because not many people are providing these services. So they bring you patient, they increase the awareness. So this all has been covered by Dr. Sujit. This is for the cluster headache, one intervention, but this is not my topic, so I am going to skip. So this is always a teamwork. This is our team, pain medicine, at Dr. Ram Manohar Lohia Institute of Medical Sciences. Dr. Shivani ma'am, our OT staff, and this is our man Friday, who is running the CM. He is the most important man in the OT, actually. And not everyone can bear pain. So we have the onus to treat it. And I am telling you, if you want to come into the pain medicine, we pain physicians are going to be the primary custodian of any chronic pain and spine condition in coming future. Why? Because there are medicinal branch for every stream. Like pediatrics, there is pediatric medicine, there is pediatric surgery. Like cardiac, cardiologist, cardiac surgery. But in a spine, there is no medicinal branch. They are us. So we are going to be the primary custodian of chronic pain, including the spine pain, joint pain, and all other kind of pains in the coming future. So it is our responsibility to treat all these patients and treat them effectively. Thank you for Dr. Ram Manohar Lohia Institute of Medical Sciences for your kind and patient listening. And thank you, Sarita ma'am, again.
Thank you so much, Anurag sir, for the enlightening session on trigeminal neuralgia, and I am sure students would have gained a lot from this session. Next, I would like to call on stage Dr. Debjyoti Datta sir. Sir is an alumni of KGMC. He has done his anesthesia from here, and sir is a FIPP member, as well as sir has done his fellowship in pain medicine from West Bengal University of Health Sciences, as well as sir is FIAPM. Sir is right now working at as a consultant at Fortis Hospital, Kolkata. Daradia Pain Hospital, Kolkata, and sir is a faculty there in pain management courses at Daradia Pain Clinic, Kolkata. Sir was an ex-assistant professor and in charge of pain clinic at the College of Medicine and JNM Hospital, West Bengal University of Health Sciences. Sir has 10 national as well as international publications, and sir is an organizing secretary of ICRA Pain Kolkata 2015 and 16. Welcome, sir. Yes, sir.
This one, huh? Okay. So thank you everybody, my teachers, my friends and juniors. So it's really feels great when I am back to my college from where I have done my MD. Maybe 15 years back I was at your seat. I was looking someone taking the lecture. But my pain journey started from this place, KGMC. My first epidural steroid is here at KGMC. Okay, and Dr. Parvez Khan sir has given me the opportunity that time. First seen case, that is ganglion impart, that is also done by Anthem ma'am, that's long back. So the thing is, KGMC was always a pioneer in teaching, and I am very thankful for this place. There were some lacunae in educational part, but it is really great to see KGMC has improved a lot in that part as well, because in our time in 3 years I have seen very few CMEs, very few workshops, but now there's more. I think I am coming here in twice in last 3 years. So it's a great initiative by definitely Ajay Chaudhary boss, Sarita Singh madam, and definitely the whole department. And in future, I think KGMC will be doing much more in pain. So let's start. complex regional pain syndrome. As the name states, it is a complex situation. Why it is complex? Because there are some pains that actually hurts you, but there are some pains that actually changes you. What the word means? That means whenever we got a pain from the receptor, suppose a pin prick. Now the pain is damaging the tissue. But once the time is over, the tissue heals. But still the pain persists, and that is not in relation with the tissue damage. Then how it can happen? Remember, pain perception is a complex thing. That means I am receiving pain. It is not because I am getting an injury, but I am receiving pain because of a complex interaction of neurons which determines my existence within my mind. And over that neurosignature, I am putting an image of a pain, and that I am actually perceiving. During this whole process, the whole network, if there is damage at any level, I can perceive pain. So, often we got patients and they come to us and say, "Sir, I have done my MRI, I have done X-ray, I have done CT. All the reports are normal, but still I am having pain. Is it a psychological issue?" The reality is no. Because what you are perceiving is not the tissue or the tissue damage or whatever is there. It is what we are getting in our complex neuronal action. So in simple words, pain can be divided into a nociceptive pain, a neuropathic pain, and this we have learned from long. But nowadays they have put a in-between structure. That means nociceptive means it is the tissue damage and pain, the simple thing. Neuropathic means whenever we are getting the complex neuronal action and pain is because of that. Usually it corresponds with the acute pain and chronic pain. But it is with exceptions also, not always the same. Why? Suppose the radicular pain. It's a neuropathic pain, but it's maybe an acute pain. Then an acute pain may be of nature which is neuropathic primarily. In the other words, it's a case of rheumatoid arthritis. So it's a case of ongoing chronic tissue damage. So in those cases, you might have a long-standing nociceptive pain. Sometimes neuropathic pain may be superimposed on it, but primarily it's a nociceptive pain. So, because there are certain situations when it doesn't fall into both the categories. Suppose fibromyalgia, suppose CRPS. So now from 2016, a new group is introduced, that is the nociplastic pain. So it's a type of nociplastic pain. The differentiation between nociceptive and neuropathic that we know from long. Usually in nociceptive pain, there is actually in relation with the tissue damage. It's a time-based pain. Once the tissue damage is healed, the pain goes. Okay, and generally it responds with the conventional analgesics. Whereas the neuropathic pain has its certain characters like shock-like, burning. So these are always may be present, and it is usually a chronic condition. Now, let me start with the history of a patient. A young boy, only 15 years aged, and it's a true story. The patient came to us with severe pain in his right hand for last 3 months, with history of near amputation injury in third and fourth digit 8 years back, developed infections, multiple dressings, presently having the scarred area. According to him, the pain starts from that particular area and gradually spreads in few days over the entire right hand. Now, clinical examination revealed neither the patient is using that hand actively or he is not allowing anyone to touch the hand. He is feeling of a chronic and repetitive friction in the scarred area, so she cannot even write, and each coincided with the onset of pain. This pain doesn't follow a particular distribution pattern. That means in a neuropathic pain, you might have a distribution pattern when you can think of its radiculopathy, like a C5, like a C6, but it doesn't follow that pattern. Or in case of lower limb, you can think of L5, L4, L1, but in this type of pain, it doesn't follow that pattern. For this patient, it was not associated with the temperature change, sweating abnormalities, edema, trophic change, significant alteration of skin, color alteration in the hand. But not all the patients will be coming like this, because I am talking about a real case and it's a particular case. For this patient, it was like that only. But for other patient, it might be present, and these are the one of the signs for which we can diagnose or suspect a case of CRPS. Now the patient consulted 16 doctors altogether, and he has 16 prescriptions with different diagnoses: carpal tunnel syndrome, Raynaud's disease, arthritis, disease atrophy, Munchausen syndrome, which is a psychiatric disorder actually, somatoform disorder. So these are few, but there are all diagnoses. What happens when these patients go to a particular physician with a particular set of complaints? They diagnose according to their knowledge, and whatever they feels the most, they put in the provisional diagnosis. Now all the test reports are normal, and the patient is on taken multiple medications, currently on amitriptyline 25 mg twice a day. Physiotherapy for that patient was not possible due to pain. So now coming the question. Now when the doctors are getting such a patient and in a busy OPD, it might think that the patient is actually malingering, okay? Because they don't want to read, don't want to do something, so the patient is malingering. So comes the confusion, disbelief, suspicion. And it's an anatomically impossible pain pattern if you cannot think this is a set pain pattern. No defined pathogenesis or diagnostic criteria, and it was thought psychogenetic. Patient may be hypochondriasis, having the saying that I am having the disease, but actually not. But just I am telling, this is not in the slide. I have came across a patient just 1 week back. The patient is referred by our orthopedician in Fortis, and there was a supraspinatus complete tear. The surgeon has operated. Now after 1 month back, the patient having symptoms of CRPS in that hand. Now he is having a distant relative somewhere in US, and he communicated to them, and they replied that the surgeon must have cut some nerve in your hand. And they came back to the surgeon, and surgeon is in a soup situation that he doesn't know what to do. So he called me and said, I am thinking it's RST. Please do an block. You see the patient. So the patient came and I checked, it was CRPS. But these patients are so resistant because CRPS is such a thing. The knowledge among the doctors, other doctors, is also very poor. So what happens when he goes to other doctor? He visited a neurologist. The patient was sent for an NCV, and the NCV result came bilateral carpal tunnel syndrome. That's why I was telling right now, the carpal tunnel syndrome diagnosis in the NCV is really questionable. Sometimes if it is matching with the clinical signs, you can accept, but in those cases it is very difficult. So in fact, bilateral, but the other hand is completely normal. Now the patient again get confused, and what's happening? It is a nerve injury. Now NCV is saying something different, so what to do? So again gone to the surgeon, shouted a lot. Again surgeon sent it to me. We have done the, I am showing that video also, we have done the stylet block and the pain is relieved. So I said, at least you are sure the diagnosis is CRPS here, but let's see how the response comes. Now here also our diagnosis is CRPS, type is NOS, that is not otherwise specified because they are not falling into an exact criteria. Now how the CRPS occurs, what are the signs and symptoms? So at the initial phase, the features like swelling, the features like diaphoresis, the features like edema, the features like shiny skin, the features like loss of hair. Sometimes these are very common in early stage, and if you touch the hands, this is a very common test in clinics. Ask the patient to put forward both the hands, compare the temperature in both the hands. So what will happen? At early phases, in most of the cases, usually it is raised. The affected limb, the temperature is raised, and the other limb, it will be cold. But at the late phases, it becomes different because that time the swelling reduces, limbs becomes a little atrophic, there may be bony atrophy as well, and sometimes in those cases there are pigmentation and there will be coldness. Okay, so there may be a hot response as well as later it may be a cold response, but it may occur in the feet as well, not only in the upper limb. So how to diagnose? It is common, and most problem is it is underdiagnosed. That is very much important. These patients are common and prevalence will be coming the epidemiological part, but these patients are undertreated. Though a good percentage of patients, around 70%, resolve spontaneously, but for others treatment is necessary, and more importantly it is the aggressive treatment that is required, because once it goes to stage 3 or atrophic stage, then treating them only option left is probably the spinal cord stimulation. In India, getting a spinal cord stimulation done for a patient, in fact in my life I have done only 5 cases. Okay, so this is so difficult because patients don't have that power, purchasing power, to put a spinal cord stimulator. So mainly based on history and clinical examination, investigations are adjunct to rule out the other disorders. What are those commonly? The diabetic neuropathy, small fiber neuropathy, entrapment syndrome, diagnostic disease, thoracic outlet syndrome, other vascular conditions. So these are the things that you need to rule out, but you cannot diagnose by any investigation. It's a CRPS. Okay, certain tests are there, the psychogalvanic test or this type of thought is there, but they are not clinically relevant. Now coming to the clinical criteria, the most important criteria I am coming, it's the Budapest criteria. So patient should have continuing pain and disproportionate to the inciting event. That is one of the very important thing. जो injury से इसको हुआ था, the initial pain and the present pain, okay, that should not match. That is one very important thing. Number 2, patient should have at least one sign of 2 or more categories below, and patient should have at least one symptom or 2, 3 or more categories below, and no other diagnosis. This is very important last time. No other diagnosis can explain these signs and syndromes. In fact, most of the cases of the nosoblastic pain, this point is introduced, okay, whether it's fibromyalgia, but this CRPS. So this should not be explained by any other causes. So among sensory, there are the allodynia. I think you all know what allodynia is, and hyperalgesia may be present. Hyperalgesia means light sensation of pain increasing. Allodynia, even touch converted to a pain. Now vasomotor, there is temperature asymmetry, skin color changes, skin color asymmetry, pseudomotor or edema or swelling changes or sweating asymmetry. Motor or trophic, decreased range of motion. This is very common. Usually stiffness occurs. Motor dysfunction, weakness, tremor, dystonia, chronic changes, hair, nail, skin changes that might occur. So these are the things, and based on that you can diagnose a CRPS. Now lot of patients, even lot of other surgeons send us as a RSD. That was the old name, that is changed. RSD actually renamed as CRPS type 1 in 1994, and causalgia, that is as a result of CRPS type 2, that is as a result of the nerve injury. Now if you compare with the type 1 and type 2, then participating event in type 1 it may be present, it may not be present, because it might be a very trivial trauma, like somehow 1 month back patient has taken a vaccine, maybe a COVID vaccine or tetanus toxoid, anything that can precipitate CRPS type 1. So in all cases you won't be able to find out that disease, but most common is the Colles fracture and the injury in the lower part of the hand. Now in the CRPS is usually type 2 is always present. Now single peripheral nerve involvement is comparatively rare at type 1, whereas in type 2 it is comparatively more common. Single peripheral nerve involvement, remember I have told it doesn't follow the nerve distribution. Type 1 it usually doesn't follow any nerve distribution. Now cardinal signs are the spontaneous pain, swelling, different skin temperature. They are in type 2, burning pain, allodynia, hyperalgesia. Progressive, type 1 is usually progressive, type 2 is sometimes progressive. Bone atrophy, Sudex dystrophy may be present in type 1, and type 2 it may not be present, usually not present actually. Now the stages, this is very important to know, because this is why it requires a very early treatment. Okay, so affected red, swollen, red, burning, increased diaphoresis, that means sweating of the affected limb. All symptoms are near the site of original etiology, that is the earliest part of the disease. Now that occurs within weeks of the injury, and next it goes to the dystrophic phase, where the skin becomes cool and also diaphoretic. Sudeck dystrophy may be present in the X-ray. Pain occurs throughout the limb, not only near the site of injury, and this occurs within the months of the injury. So usually we try conservative management with exercises and medicines for 3 or 4 weeks. Then we jump for the sympathetic blocks. Now among the atrophic changes that occurs usually years after the injury, and this is the worst case. In fact, I have one patient very poor in this phase, atrophic phase. The patient is having pain for I think last 10 years, because I have first seen the patient when I was in a government service there in 2013. Still the patient is taking amitriptyline, but still the pain is severe and the patient cannot afford any other costly treatment. In fact, we have done the sympathetic block for many times. Initially that responded, but later it doesn't respond even. So in those cases, actually good case for the cord stimulation, but the patient is not able to afford. So skin becomes pale and shiny, atrophic muscles and bones in the affected limb, pain may be consistent with the treatment, and this occurs with the resistant, when it becomes resistant to the treatment, this occurs after years. Now, causalgia, superficial pain, it is not deep, early vasodilatation and late vasoconstriction, impairment of the motor function, swelling and diaphoretic changes present are more discrete, no changes in bone metabolism. And CRPS NOS, the patient, what I have told, that when you are not able to distinguish them in any two of the categories. Now coming to the epidemiology portion. So genetic predisposition, AHLA, DQ1 antigen associated. These things I don't understand very much, associations, okay, just remembering, that's all. Incidence is 5.46 per lakh persons per year. So it is, I should not say it is very common, but it is such a population that we do not diagnose. That means a good number of patients is below the water of the iceberg. Okay, you only see the very small tip. Median age of onset is 46 years. Presence of fractures is usually found in 46% of the patient, and I have told around 70 to 74% patients there is spontaneous resolution. Now coming to the more difficult part, that is pathophysiology. Now for the clinicians, digging deep into the pathophysiology is difficult. I will actually see you the important parts only. So abnormal somatosensory pathway, abnormal sensory pathway, sympathetically mediated pain, that's why we can do the sympathetic blocks actually, and definitely there is immune dysfunction. Immunity plays a role here, and ultimately it is the sensitization. So already the mechanisms of central sensitization we have, actually it's not scope for today, but definitely for the origin of the neuropathic pain, it's a sensitization that is responsible. Coming to the sympathetically mediated pain, that is autonomic dysfunction is the key here. Now type 1 and both type 2 have the features of the sympathetically mediated pain, and the signs of such a sympathetically mediated pain is burning nature, touch evoked allodynia, cold allodynia, numbness, rhizesthesia, heat evoked allodynia. And to confirm it sympathetically mediated, either sympathetic block work as a diagnostic to reduce the pain, or other sympatholytic agents can give the relief. So sympathetic nervous system, there is afferent sensitization by the chemical compounds. There is development of the aberrant synaptic connections, increased adrenergic receptor density, ultimately leading to this vicious cycle. This is important. Otherwise, you can say, I am doing the sympathetic block one time. So it's given steroid and local anesthetic. How long the local anesthetic will work? Only 2 hours, maybe when you use lignocaine. How long the steroid will work? If you use depot, maybe 3 weeks. But how the pain goes? Because this pain cycle is broken by the drugs. Okay, once there is a pain relief state that blocks this cycle and they reverts the ways of sensitization. Okay, so minor noxious stimuli in the area of affected causing the severe intensity that causes an altered physiological state, then CNS sensitized state, and they again causes the severe pain and increase in duration. So this is one of the newer studies to dig into the pathogenesis of CRPS. So first part of the pain is attributed by the local tissue damage. But within weeks the tissue heals and the pain due to local tissue damage reduces, just following the red line. Then the pain processing system abnormality that leads, okay, and their abnormality continues, endocrine mechanisms comes into play, that continues, immunologic mechanism comes into play, that continues. So it's a really complex interaction between the things. Now there are certain investigations that is a little bit helpful, like quantitative sustained testing, autonomic function testing, temperature measurement, vascular abnormality, traffic change measurement. So, but no one gives a clear-cut diagnosis that it is CRPS. So all can give you some diagnostic clues only. Coming to the treatment. Remember, it's a complex chronic situation. Treatment should always be multimodal. That is the key. That means if you think that I have learned the sympathetic block and I will be doing sympathetic block, that is cannot only cure the disease. You have to take always a multimodal approach. So first of all, physical medicine is a very important part, restoring movement is very important part, as well as psychological treatment for the patient is very, very important. Okay, so treatment, we have to make the treatment algorithm to normalize the functions, treatment plans tailored to tackle the individual problems, comprehensive diagnostic and evaluation. But sympathetic block helps in those parts also. When I told that patient, see this, I have done the sympathetic block and now your pain is over. So it means your nerves are not injured. What the patient was thinking, by my nerves are injured. Now patient is assured that his nerves or her nerves are not injured. So that is the advantage of doing the intervention as well as the psychological management. Now early and successive therapeutic interventions prevent the onset of irreversible type 3. Now the other pathways are the assess and release the clinical and psychological state. Be consistently supportive. This is very much important. I know in government institutions, being or doing or talking with the patient too much time is difficult, but for these chronic cases, it needs to be done. Strive for maximum pain relief and functional impairment, and treatments like pharmacological management, sympathetic blocks, rehabilitation program, and mainstay is the sympathetic efferent blockage. Now drug therapy, I am just covering the headings because I think I have very close to 30 minutes, may have crossed. So first of all, tricyclic antidepressants, amitriptyline, nortriptyline, one of the very common medications, but be careful of the side effects, and in the hypothyroidism or IHD, we will try to avoid and will try to manage the other cases as well. Okay. Now anti-epileptic drugs, very commonly prescribed gabapentin, oxcarbazepine, pregabalin. So they can give relief in this neuropathic pain. NSAIDs are effective only when there is inflammation. Peripheral vasodilators, yes, it works, and we commonly prescribe the nifedipine, usually 10 to 20 milligram retard preparations. Next, lignocaine jelly for the local action, and definitely you can use the lignocaine plasters as well for the local, only when it is only localized, because otherwise it becomes very costly for the patient to afford. Now opioids and other drugs can also be used, ketamine infusion, okay, oral clonidine, midazolam, but this sensitization, programs are effective but usually taken at the last. Now steroids only for the short period of time, and opioids can be given as the other drugs. Now coming to the sympathetic blocks, definitely takes a good part. Now this is our whole sympathetic chain from top to bottom, and where we can block at the level of the stellate, at the level of the thoracic T2 T3 level, at the level of the celiac plexus, at the level of the lumbar ganglia, at the level of the hypogastric plexus, and then at the level of the ganglion impart. These are the standard areas of the sympathetic chain where we actually block for the different areas. Okay, so these are the areas where you can actually block to get the diagnosis and get the therapeutic effect. Now when we started blocking, then it was all blind. My first stellate was a blind stellate. Okay, just palpating the chassis next tubercle and then putting. Then it became fluoroscopy guided. But now the stellate is completely ultrasound guided. This is for the patient I just told about. I have done this week actually, sent by orthopedician. The patient was very apprehensive, so I could not get the time to put an ecogenic needle. Patient was almost giving no time. So I have done with the intramuscular needle only. So you might find a little bit difficulty in seeing the needle. See, here is the needle, and this is the longus colli muscle. Okay, this is the guide. Basically, this C6 tubercle and the longus colli are the very common guides, and carotid is anterior. We have to be posterior to the prevertebral fascia and slightly in between the fascia covering the longus colli. So here at this point, okay, just over the longus colli, but we should not be in the carotid sheath. So that is how we put a stellate block. And this is an example of another patient. We have done a very aggressive block with a continuous stellate ganglion block with pregabalin. So basically these are the aggressive multimodal effect with the very difficult cases. But when everything fails, it is actually the cord stimulation, and that we know it's a costly thing, but we have to do first trial stimulation and then we have to go for the definitive stimulation. In rehabilitation part, we have to go for the physiotherapy, vocational rehabilitation, recreational therapy, cognitive behavioral therapy, and mirror therapy also. Okay, especially for the stiffness, this mirror therapy also helps. It is just tricking the brain and giving some other messages. Suppose my left hand is stiff, put a mirror in front, see the right hand and ask the patient to move the right hand and look at the mirror to see the left hand moving. Okay, so it is a way to decouple the pain sensation. The patient is having a sensation that when I will move the left hand, I will be having pain. Now the patient is seeing my left hand is moving, but I am not receiving the pain. So it is a process of modification of the thought. So this was the plan of the management. So stellate ganglion block with local anesthetic, then we can go for a longer time block with the RF. But here usually what we use is the pulsed RF because a lot of other important structures are present. And in resistant cases, we can go for a brachial plexus block. If you are thinking it is sympathetically independent, then to break the cycle, you can go for a brachial plexus block with the local anesthetic or steroid also. Among the other modalities, we could have put the SCS, peripheral nerve stimulation. So peripheral nerve stimulation still it is not available here, but SCS is available. Other medicines, newer medicines can be tried like parmedoethronate is type of medicines which are coming up. So they are safer, so can be tried. And there are certain studies where the amputation is done, though I have put a question mark because the study ultimately concludes that it is not very beneficial. Okay, acupuncture and other therapies, definitely a lot of studies are there, but we cannot say what is actually beneficial. These are the literatures on which we have actually made the slides. Now, in current understanding, we can say there is accumulating evidence and association between the CRPS1 and the damage of type C and alpha A delta fibers. Appears hypothesis of a small fiber neuropathy, but still more researches are needed in this field. Pain is the most common syndrome. Better understanding of the CRPS and the whole of overactive sympathetic system and technical advancement treatment modalities help making the accurate diagnosis and controlling the symptoms and thus prevents the irreversible atropic change. Still continued research needed to convert the symptoms for treatment approach to the mechanism targeted treatment approach with a tailored treatment plan according to the individual patient's requirement. That is the most essential thing. So you should consider, do not consider that is the one medicine treat for all. We have to individualize the patient's condition, as we are not digging in till now able to go into the root of the cause of the CRPS. So till that it's a complex condition, we need to pick up the cases early, we need to treat it aggressively so that we can give a good result. At least the patient is able to lead his daily life, because otherwise these are such a conditions that makes the patient's life impossible. It is not like cancer, it is not killing the patient, but it is making the life actually miserable. So that's all with the message. Let me end, and thank you madam, thank you sir for calling me here.
Thank you so much, sir, for the amazing session. Now, I would like all the delegates to please be seated, as we are going to have a quiz session. And the link for the same will be shared on the WhatsApp group. And there will be around, and there are 3 prizes as well, first, second and third prize. So whoever gets the most number of correct answers will be given the prize. There will be a time limit of 10 minutes and there are 15 questions. So we are sharing the link on the WhatsApp group and we are starting the timer. Okay, so are the links available to you? You can start.
बंद है भाई काम करते ना सुनो कॉलेज में सप्लाई के किनारे का नहीं नहीं इतना कॉलर माइक दे देता हम सबसे कॉलर माइक के स्पीकर को लगा के इतनी अच्छी आवाज़ देता है अरे हम यूट्यूब पे भी भेज देते तुम्हारे आगे और क्या तो इसी से ना भी सीधे माइक उन्हीं के फ़ोन पे पकड़ा के सर ये लीजिए फ़ोन की स्पीकर लगा के टर्न आई तो दिमाग फ्रेम खराब हो गया जबरदस्ती डॉक्टर की तुमने कहा 3 दिन चले
So results of quiz is here. Anjali Singh from SGPGI, third. Please come forward. बंद नहीं करो यार. I would like Sarita ma'am to felicitate. Second is Mohit Kishore Srivastav. And first is Vidula Bansal, SGPGI. Thank you all.
So we are going to the last lecture of the CME. Before so just to provide an information that we will be sharing a feedback of the CME as well as tomorrow for the workshop. So please fill the same and send it back to us. We'll highly appreciate it. So the last lecture of the day will be taken by Dr. Sandeep Kuba sir. Sir is associate professor in the pain unit in the SDPGIMS Lucknow, and sir has a number of publications, 8 national and 16 international publications for the same. And sir will be now taking over and talking about cooled RF versus conventional RF in osteoarthritis knee. Thank you, sir, and welcome, sir.
Thank you, Abhishek, for the nice introduction. I think you all were waiting for me. Okay. I'm going to discuss about the role of radiofrequency treatment in knee osteoarthritis pain. Okay. If you look at the knee joint, the number of structures are there in which degeneration happens, and that lead to a painful condition that is known as knee osteoarthritis. So it's a degenerative disorder of the joint associated with articular cartilage damage, with bone attrition, osteophyte formation, and ultimately loss of joint function. And it is most commonly seen in weight-bearing joints, that is knee or the hip joints. So we are going to focus upon knee joint. So if you look at the epidemiology, is that 13% of the females and the 10% of the males more than 60 years of, they have got symptomatic osteoarthritis. So in nutshell, 10% of the population is suffering from osteoarthritis who are more than 55 years of age. The prevalence, its prevalence is more in females as compared to males, and also severity of OA is more in females. We can categorize the severity of OA according to Calgren and Lawrence classification into grade 4, or sometimes it is given in literature in 5 categories, depending upon as the severity progresses, the grade increases. So for the management, number of options are there that includes non-pharmacological, pharmacological, interventional, recently, and the surgical. Now, both non-pharmacological and the pharmacological interventions, they have got not much role. They have a number of therapies have given, like education of the patients, occupational therapy, exercises, acupuncture, and all sorts of treatment. And they are only beneficial in initial stages of osteoarthritis. Okay, in the later stages, they have not got much role. Now, in pharmacological, all sorts of analgesics, ranging from paracetamol, NSAIDs, opioids, they all have been used for the treatment of knee osteoarthritis pain, but they have got very limited efficacy and very limited role. Now we are left with only 2 options, that is interventional and the surgical. So we are going to focus upon intervention because in surgical, for the surgical treatment, most of time it is TKR which is being done by the orthopedicians. But there are subset of patients are there who are not suitable for TKR and who do not opt for the TKR. So for those category of patients, we have got another treatment option, that is interventional. So to do the intervention, particularly in per se genicular nerve block, it should be given to those patients who are having moderate to severe knee pain of osteoarthritis origin more than 3 months of duration, that is having chronic knee pain, and who are having Calgren and Lawrence grading of osteoarthritis 3 and 4, who failed conservative therapy. Okay, you have exhausted the analgesic therapy, the exercises and all, then we are left with intervention. And it is being done in 2 stages. First is diagnostic and another is the treatment modality, the final treatment modality. So only those patients who got more than 50% pain relief on diagnostic, you should offer these patients the treatment modality, that is radiofrequency treatment. Okay, the contraindication for this treatment is like any regional anesthesia, that is infection in or around the knee joint or patient diffuser or coagulation abnormalities. Now, for genicular nerve block, you can use the ultrasound guided and the fluoroscopic approach both. Now let's have a look at the nerve supply of the knee joint. This is very important. Okay. Now knee joint gets all sorts of nerve supply from all the major nerves in the lower limb, that is femoral nerve, tibial nerve, common peroneal nerve, and the obturator nerve. Okay, but we are focusing upon the three nerves, that is superior lateral, supromedial, and the inframedial genicular nerves. Why? Because this is the vascular supply around the knee joint. Now each of these three nerves, that is supralateral, supromedial, and the inframedial nerves, they are being followed by their respective arteries. So on ultrasound, because these nerves are very small, like a twig, so we cannot visualize these nerves on the ultrasound. Okay, but the vessels we can visualize. So it is easier to block these nerves by following the vessels, and also the location of these nerves are fixed in respect to the knee joint on the femoral side and the tibial side as well. Okay, so these are most easily to block. That's why. And one point is also there. So if you see overall nerve supply of the knee joint, it is approximately 10 nerves who are supplying the knee joint. So we are blocking only the 3 nerves because we do not want a charcot joint. Okay, so even if we block 3 nerves, 7 nerves are still there who can serves as a sensory receptor for the knee joint. Okay, so we do not want a charcot joint. Okay, our goal for the knee pain of for the osteoarthritis origin in a patient is to have adequate pain relief, not the complete pain relief. We target only 50% pain relief so that the quality of the life of the patient improves. Okay. So here is the location of superior lateral genicular artery, superior medial genicular artery, and the inferior medial genicular artery. Okay. This image is being taken from a paper that was published in journal Pain in 2011, and they dissected the tissue around the knee joint, and they have shown that these nerves are being accompanied by these arteries. So in my institute, I use ultrasound to block the genicular nerves. Okay, so this is how you block a genicular nerve. Okay, then you have to place the ultrasound probe around the knee joint on the femoral side at the junction of diaphysis and the epiphysis. Okay, and when you place this in a axial view, okay, when you place your probe, you will see the pulsation of genicular artery. So here you have to focus on the genicular artery. Okay. Once you visualize the genicular artery, you can give 1 or 2 ml of local anesthetic, either lignocaine 1% or bupivacaine 0.125 to 0.25%. Okay, so this is how you block a genicular nerve. Sorry. Now, after you have given genicular nerve block, after you have given genicular nerve block, you should see how much pain relief the patient is having. In my experience, if the patient have more than 50 pain relief, at least for 24 hours, then I consider it to be a positive diagnostic block. Okay, and thereafter I subject these patients to radiofrequency treatment. Okay. Now the radiofrequency treatment of the genicular nerves that can be done by 2 ways: the conventional, by use of conventional radiofrequency needles, and by cooled radiofrequency needles, and they are very particular special kind of needles. Okay, now how these needles work I discuss later on in my slides. Now why these three genicular nerves we approach with this? They have got fixed location. Okay, so they usually lie on the lateral side of the femur and the tibial, on the middle to posterior part of the bone. Okay, so for the radiofrequency treatment, the needle has to be parallel to the nerve to have got the adequate thermal ablation. So that's why we use fluoroscope for this. Okay, so this is how you place a radiofrequency needle. Okay, so you can see that now the needles are lying parallel to the bone. So the needles are parallel to the genicular nerves. So this is how you see in AP view and the lateral view. Pointer. Okay. This is the AP. You can see this is the needle and this is the lateral view. You can see that the tip of the needle is lying in the middle part of the shaft. Okay, so this is the location of the genicular nerves. Okay, once we locate the genicular nerve, we do the sensory and the motor stimulation. Sensory stimulation at 50 Hz and the motor stimulation at 2 Hz. And on sensory stimulation, if the patient says that he is having knee pain, on stimulation of the nerve less than 0.5 millivolt, then we consider to be a positive thing. Then after that, we subject the patients to thermal ablation. Okay, thermal ablation is being done at 80 degrees Celsius for 90 seconds. So in this way, we ablate all the 3 genicular nerves. Now, cooled radiofrequency ablation of the genicular nerves. Okay, so this is the machine which we have got in our institute. So this is the radiofrequency machine which supplies, or you can call it radiofrequency generator, and this is the pump for cooled radiofrequency apparatus. Okay. Now the function of this pump is to move the water. Now how the cooled radiofrequency works. So this is the typical needle of cooled radiofrequency. You can see that one channel is for attachment to the radiofrequency generator, and these 2 pipes. You can see these 2 pipes are to connect with the pump, which circulate the water through the needle. Now this is a normal radiofrequency needle. Okay, you can see that this is the needle and this is the probe, the thermal probe. The thermal probe is there, and this is the radiofrequency needle. Okay, and this is the insulation which is there on the radiofrequency needle. On the tip is bare, through which the lesioning happens. And how? This is the lesion area which is being produced around the tip of a radiofrequency needle. So any tissue which is in the vicinity of this nerve, it is going to be burned. Okay, so we usually do the lesioning for 90 seconds. Why? The maximum lesion size is produced only by up to 90 seconds. So if we increase the duration above 90 seconds, it is going to char the tissue. Okay, so there is no appreciable increase in the lesion size, but the charring of the tissue is done. Okay, so it is not beneficial for us because it is going to burn the surrounding tissue. Okay, so what is the way to increase the lesion size? So the cooled radiofrequency now comes into play. Okay, so this is how a cooled radiofrequency needle looks like from inside. You can see that this is the needle, this is the probe, sorry, this is the probe, and this is the needle, and a water channel is there. So this is how the water moves around the needle tip. So what happens when we do the lesioning with cooled radiofrequency needle? It keeps on dissipating the heat around the needle tip. So by doing this, the area is enlarged around the cooled radiofrequency. So the benefit of cooled radiofrequency is in particular, if I want to say for genicular nerve block, is that even if variation in the anatomy of the genicular nerve is there, because we are creating a larger size, larger lesion, so it is going to include the nerve. So this is the benefit of cooled radiofrequency needle as compared to conventional thermal lesioning. Okay, so our lesion size is bigger, and we can give it to longer duration. Like for conventional thermal lesioning, we give it to up to 90 seconds, but for cooled radiofrequency, we can go up to 150 seconds to increase the lesion size. But it comes at a cost. The needle of the cooled radiofrequency is much approximately 10 times costlier than a thermal radiofrequency, conventional thermal radiofrequency needle. this is my experience, which I published in an international journal, and this was a retrospective observational study, and I published data of 60 patients. I followed these patients up to 1 year, and I found that the thermal coagulation or the radio frequency treatment of genicular nerves, it provides pain relief up to 1 year. Okay. And this study I have done in grade 3 and grade 4 Calgallan and Lawrence patients. Okay, so these are advanced patients, and these kind of patients, they have exhausted all the conservative treatment. Okay, so I've used it, and it can give the patients 1 year of life, adequate pain relief. I will not say that it is completely pain relief, but adequate pain relief is there. Now I have found 2 systematic reviews and 1 systematic review and meta-analysis to compare the 3 techniques. Okay, the 3 techniques for genicular nerve block lesioning is conventional, that is the standard thermal lesioning, the pulse radiofrequency, and the cool radiofrequency. So this was this systematic review was published in 2017. So they include number of studies, particularly randomized control trials, and they concluded that out of these 3 treatment modalities, there is not a much difference in the efficacy. Okay, and all the three treatment, they provide up to 1 year. The effect of pulse radiofrequency lesioning is given in the literature up to 6 months, but the standard thermal lesioning and the cool radiofrequency needle, they give pain relief up to 1 year. Okay, and there is not a much difference. When I think cool radiofrequency was introduced, I think 10 years back, when it was introduced in the pain medicine, there was very much hue and cry about that certainly it will give much of a significant pain relief as compared to thermal lesioning. But earlier paper, they showed also this thing, that the cool radiofrequency is better than the conventional and the pulse radiofrequency. But in 2017, this meta-analysis the systematic review concluded that all the 3 techniques, they are equally efficacious up to 1 year. Okay, pulse radiofrequency up to 6 months, and both of these up to 1 year. Now this is the latest. This is also a systematic review and meta-analysis, and this review also says that now this meta-analysis, they have included more recent studies, and they are all concluded that all the 3 modalities, they are not very much different as in terms of efficacy. Okay, but in my personal experience, the effect of cool radiofrequency, it lasts longer as compared to thermal lesioning. Okay, maybe in the future I will try to publish my data, but in my own experience, it works slightly, gives more pain relief as compared to conventional. Okay, so this is all from my side. Thank you very much. If you have any question. Certainly I have not bored you. If any question, I would be happy to answer. Yes? Actually, for the early neocytes, a number of interventions are there. For per se, I say, you must exhaust all the conventional treatments, all the conservative measures, and also the PRP therapy is coming in a big way. Okay, although the literature says it is not beneficial, but in my experience, the PRP works wonder in some patients who are in early osteoarthritis. Okay, so studies are not being done. That's the thermal lesioning studies are only in grade 3 and grade 4 patients. Not much data is there on early osteoarthritis. Look, if you look at the perspective of a patient who is in pain, okay, and who do not want to undergo any TKR, okay, and he has exhausted all conservative treatment. If a procedure of 1 hour duration, it can give him 6 months to 1 year of adequate pain relief, not complete pain relief. So I must say we should go for it because it is giving 1 year of at least, and you can repeat it. There is no harm in repeating this procedure. Okay, that's all. Thank you. Thank you.
Thank you, sir, for enlightening us on the various modalities of treatment of osteoarthritis knee. I would like now call sir, ask Sarita ma'am to felicitate Sandeep Kuba sir. Now I will request Ajay Chaudhary sir to please come on the desk and so now we will be concluding the session. I will ask all the CME delegates as well as CME plus workshop delegates. They can collect the certificate from the counter here. Thank you so much for your support and efforts. So those candidates who are registered with us in workshop will be meeting at 8:30 a.m. in the Department of Anatomy tomorrow. So we'll start by sharp at 8:30 a.m.